thank you for being so in time.
Oh, well, my pleasure. How was yesterday? How went your day yesterday?
It was good. It was good, actually. I mean, it was like a dry run. It was our very first experience in this kind of a webinar, but everything went well in time and with a lot of attendance. We have about 80 attendants representing 23 countries. So it's a huge meeting.
So let me ask just if you can see my presentation, and probably in order to improve the quality of the connection, maybe you won't need my camera on when I start the presentation. Let's say. Can you see this now, or?
We are now seeing you, only your webcam.
Let me see.
Okay.
Okay, now the PowerPoint is.
Okay, we are now seeing your whole screen.
And are you now seeing the presentation?
No, we are seeing your screen. We are seeing your Google Meet window.
Yeah.
Okay, let me see.
I see also Giovanni. Hi, Giovanni.
Hi, Giovanni.
Good morning.
How are you doing?
Yeah, quite well. Many things, but apart from this, doing well, as always.
Okay.
Are you seeing it now?
Let's see. Now we are seeing a black screen. It seems like you are presenting, but we see the black screen and also you on your webcam. Maybe you have to select a window, and you have to select the PowerPoint window.
Which is what I did, actually. But...
Okay, but until you haven't opened the PowerPoint window, we don't see anything. So only when you open PowerPoint.
Because it's open, actually.
It's open.
And it says to me that I'm presenting, but you can see it, right?
Actually, I can see it. I can see the PowerPoint presentation, but not in the full screen.
Okay, and now, Giovanni, can you see in the full screen?
Not yet. No, it's just like a frame.
Okay, so let me try to reconnect. Is that okay for you?
Okay.
Yeah.
Okay.
Because we should start at 10:50, no? So we have 10 minutes.
Okay, now we see, finally we see something. We see the PowerPoint now.
Yeah.
You see it, but
yes.
you don't see it in the full screen.
Yes.
Now you see in the full screen?
Wait a second. It has some delay, maybe, due to connection.
So let me see if I can interrupt the camera, which we don't need, as I was saying. Let me see.
Vediamo. Hi, Ilenia. Meanwhile, I can say a few words to introduce the ECNP network, while we are arranging the PowerPoint for Professor Bernardo Dell'Osso. we have 10 minutes before the beginning of a presentation. So, okay.
Stefan, can you hear me now?
Yes.
Yes.
But can you see also the presentation?
No, we are only hearing you.
Okay, let me see.
Mm-hmm.
Can you see it now?
Yes.
Yes.
Okay.
Okay.
Now it's
Okay.
okay. Okay.
You can see it in full screen?
Yes, we can see the whole screen, not in presentation mode, but with the slides on the left side. But slides are visible.
Because it's on full screen in my laptop. I don't know why you can just see on the side. Let me see if I can improve it.
Anyway, it's better if you enter full screen mode, because now we see only cut of the screen. In full screen is better.
Well, I'm in full screen in my laptop now, but I don't know if you can see it in full screen or.
So we see in full screen now, no?
It's
Yeah,
okay.
it's okay.
It's okay.
Yeah. Okay.
And if I go ahead, you can follow me, moving the slides ahead, like I'm doing now.
It's always on.
I think that you have to move your own slides.
Which is what I'm doing, but you can see the first slide and then the second one, so you can.
Yes.
So okay, so you are seeing me moving the slides.
Yes.
Which means you follow me. Okay, so it's.
Okay, let me say good day everybody, and thank you for being here today. First of all, to the faculty. This morning we are going to listen to Professor Bernardo Dell'Osso and then Professor Giovanni Martinotti, and later Professor Joseph Zohar. I want to take the occasion, we have a few minutes before the 10:15 tea time for the presentation of Bernardo, to introduce you a little bit the ECNP network and thematic working groups. This is the first initiative of these ECNP networks, and I'm very pleased and very thankful to the ECNP European College of Neuropharmacology that is also promote itself as a neuroscience applied society for bringing together researchers from different areas of Europe and not only Europe to foster successful collaboration and sharing of ideas. This organization of network is oriented in some cases to specific disorders of the brain or to specific methodology, like this network that is based on the non-invasive and invasive neuromodulation, and is a response of a community of neuroscientists to the ongoing development in brain research and the changing nature of European international research funding. One of the other reasons of this collaboration is, in fact, to create a network in provision of application for European and not only European grant. There are several networks that are old from the ECNP, ADHD, anxiety, bipolar, Down syndrome, experimental medicine, immunopsychiatry, and then neuroimaging, neuromodulation, like this one, nutrition, obsessive-compulsive related disorder that is offering a good collaboration as well to this initiative. And each network is published on the website of ECNP with an affiliation of each member. And I encourage you to have a look of the activity on the website of ECNP and to participate, because this is really the aim of this meeting, not just to offer some education, but to motivate young middle career scientists to collaborate to the activity of ECNP, and more specifically to the Neuromodulation ECNP thematic work group that I'm honored to chair at the moment. So neuromodulation is especially TMS, is now a rising interest in the field of clinical science, but the adoption of this new methodology involves a broader culture. Like yesterday, we listened some presentation concerning the basic concept of neuroanatomy, the basic concept of physiology that are not common knowledge in the field of clinical psychiatry. But this initiative doesn't rise in the just in the psychiatric area, but is the most broader one of the neuroscience and for the application neuroscience. So I'm very thankful. I'm very thankful to the ECNP for this occasion they give us to involve such a huge number of attendants and such a high quality faculty. Yesterday we had almost 80 attendants and in representation of 23 countries, and hopefully today will be the same or even better, even if it's Saturday. And we are especially thankful for dedicating your weekend to these events. So I don't want to take any time to the presentation because I'm sure that they're going to be very, very interesting. And also after the morning session that is going to last from 10:15 to more or less 1 p.m., we will have a short break of 1 hour. And then after that, we have the practical application of TMS workshop with Dr. Anna Maras and myself in part about neuronavigation, targeting, and practical application of DTMS and theta. So hope you will have a nice morning. And let me introduce Professor Bernardo Dell'Osso, that is Associate Professor of Psychiatry, University Milan. He's a Director of Psychiatric Clinic at the University Hospital Sacco in Milan, and is also part of an outstanding group of research on bipolar disorders at Stanford Medical School of Medicine, Palo Alto, California. Thank you, Bernardo.
Dr. Bernardo Dell'Osso is a psychiatrist and currently director of the psychiatric clinic of the Ospedale Sacco Polo Universitario in Milan, and associate professor of psychiatry at the University of Milan.
Thank you. Good morning. Can you hear me?
Yes.
Yes. Okay. So good morning to all the participants, and thank you to Professor Stefano Pallanti and his collaborators for putting this together, for organizing this masterclass, and to the ECNP for thematic network for supporting it. So my talk today is going to be focused on the use of transcranial magnetic stimulation in major depression, with specific emphasis on research acquisitions and clinical correlates. Also trying to provide you a little bit of history, as I've been involved in TMS since early 2000 years, also with Stefano Pallanti back in those years at Mount Sinai Medicine in New York. And so also trying to give you the flavor of what happened during these 15 years of in the specific area of major depression, and briefly touch some points about future perspectives in this field. Now, TMS, as Professor Pallanti was mentioning, is certainly considered a major topic, not only in brain stimulation, but I would say in the whole neuropsychiatric field. And studies in this area have constantly grown over the last 25 years. And in particular, over the last decade, And you can see here, in particular, in the field of major depression, where you can see, particularly in the last decade, as I was saying, a constant in terms of number of publication using PubMed as source. Understandably, different aspects contributed to such a massive development, also because considered as safe and more importantly, a non-invasive intervention for the treatment of specific psychiatric disorders like major depression. In this slide here, you can see, I would say, the whole range of brain stimulation techniques. And of course, there's a big difference are referred to as non-invasive brain stimulation because these techniques do not require anesthesia, generally present a favorable profile of side effects, generally no adverse, totally different when we move to other application, a surgical implant, which is extracranial for vagus nerve stimulation or intraparenchymal for deep brain stimulation, up to functional neurosurgery. Well, I'm saying this because when we talk about the invasiveness, refractoriness of treatment response. So what I'm trying to TDCS, so to this non-invasive brain stimulation, we are likely picturing a and we have some literature. I'm going to focus on some specific studies. Particularly in the field of major depression, is an individual with a low level of treatment response. So I'm among who strongly believes that we should think about proposing TMS to patients not when they are really treatment resistant. So for patients probably with very severe and treatment refractory depression, probably we should think also about other more invasive techniques, and probably think about using TMS at the earlier stages and not when a patient has already developed a strong level of treatment resistance. Now, I'm sure you already heard the fundamentals of TMS from previous lectures yesterday. So I'm just going to shortly recap here something that you already know. So what is TMS? TMS basically is an electrodeless electrical stimulation in which electrical energy flowing in a coil induces a magnetic field which has the ability to pass unimpeded through the skull and then induce an electrical current in the brain. So this is the basic. And have you certainly heard yesterday, protocols of TMS can be distinguished according to specific parameters. Probably the most important among these parameters are intensity, which ranges generally between 80 and 120% of individual motor threshold.
Bernardo, sorry to interrupt you. We are having, it seems, some connection issues because we can see your slides moving. I have some also messages from participants. So they are on the first slide, they are stopped.
Okay, so
okay, so we should try to set it up.
You are seeing the screen now?
Yes, we are seeing the screen, but on the first slide.
You are not moving on the.
Okay, now yes.
Okay, and
yes,
now is better.
Yes, I think yes. Now it's moving towards the slides. It's okay.
But you could hear me for the first slide. Okay, but not
yes,
but not see the screen, right?
Yes, we heard you. Some connection issues. Sometimes we have lost your voice, but I think it's comprehensible anyway. But now we can see the slides moving, and it's perfect.
Okay, so just let me go back very quickly. So in this slide, I was just showing what happened in the field of TMS over the last 20 years. And I was pointing that particularly in the field of major depression, there has been this green line you can see here, a constant growth of publications if we use PubMed as source. Then I was talking about the level of invasiveness of these techniques of TMS and TDCS in particular, and I was trying to link the invasiveness profile, which is considered favorable not only in terms of side effects, but also in terms of lack of adverse events, to the level of response of patients candidate to TMS. In other words, I was trying to stress the concept that TMS and TDCS should be proposed to patients with major depression, probably at earlier stages than what has been done over particularly the first years of clinical practice with TMS in the field of major depression, because we have some literature showing that the lower the level of treatment resistance, the higher the level of response that you can have with TMS, and probably reserve more invasive techniques, brain stimulation procedures like vagus nerve stimulation or deep brain stimulation to patients with more severe level of treatment resistance. I was also mentioning the basics of TMS, which I am sure participants already heard about yesterday from previous lectures, mentioning that TMS is basically an electrodeless electrical stimulation in which electrical energy in a coil is able to induce magnetic fields that have the capacity to pass unimpeded through the skull and then induce electrical current in the brain, which means cortical changes of polarization, particularly in the first 2 to 3 centimeters with traditional TMS. And I was also talking about main parameters. I hope now you can follow better the flow of the slides. If I don't hear anything, I'm keeping on this way. And I was saying that 2 parameters in particular, intensity and frequency, are very important for setting optimal protocols of TMS for patients with major depression. Intensity ranges between 80% and 120%. We have frequency dividing protocol generally in slow frequency, low frequency, TMS generally 1 Hz or less, and high frequency generally above 10 Hz. But we have also to take into consideration the overall duration of a single session of TMS, which generally can last from a few minutes with patterned TMS like theta burst stimulation to 40-45 minutes with the traditional TMS protocols. Also, the inner train interval, which generally is present, particularly in those protocols with high frequency TMS. The overall duration of trial, because generally we believe that, and literature confirms that 20 sessions of TMS, generally over a period of 4 weeks, is probably considered at present time the standard. But we also know that there have been, particularly in recent years, studies showing that protocols of accelerated TMS, meaning more sessions per day, can be as effective as traditional TMS, with the advantage to reduce the overall duration of the trial. Now, I don't know if you can see this short video here. So this was the experience of I would say a classical setting of TMS in a patient with major depression with a traditional device. This was taken at our institution in a patient treated with TMS through, as you can see, a classical 8-figure coil. And if you could hear the audio in this video, this was typically a high frequency TMS over the left dorsolateral prefrontal cortex. But what is the neurophysiologic background for the use of TMS in major depression? So I'm sure you covered this topic already in previous lecture, but just to recap, it is now well established that pathophysiological models suggest that two major groups of brain region, a dorsal and a ventral network, actually account for the formation of the different symptoms of depressive disorders. And within this framework, we believe that depression involves concurrent hypoactivation of dorsal prefrontal regions and hyperactivation of ventral prefrontal regions, particularly at the level of the left hemisphere. Therefore, in order to achieve a response or symptom remission, we need to facilitate hypoactive dorsal brain regions and to inhibit hyperactive ventral areas, which is actually what the two main protocols of TMS, respectively high frequency TMS on the left dorsolateral prefrontal cortex and low frequency TMS on the right area are aimed to do. So ultimately, not only TMS, but also VDCS, though with a different mechanism of action, are actually supposed to restore the functional balance between these areas, between these cortical areas, but also between the two hemispheres. Another consequence of the vast literature on TMS in major depression actually led to a very important consequence, which was represented by the FDA approval in late 2008 of TMS for patients suffering from major depressive disorder. And as I was stressing in the previous slide about invasiveness, here you can see and you can read the approval that was made by the FDA and the indication in particular. You can see here patients who have failed to achieve satisfactory improvement from antidepressant treatment. So this, we can say, is a pretty broad indication. And more important, is a totally different concept compared to treatment resistance. Because failing to achieve satisfactory improvement from just one trial of antidepressant treatment can, for instance, involve just a poor response or inadequate response if we are reasoning in terms of Hamilton Depression Rating Scale scores or Montgomery-Åsberg. We may talk also about something in the range between 25 and 50% reduction. So it's different from not having responded at all to several trials with antidepressants with different mechanisms of actions also combined. So it's different. And since the first approval in 2008, in these 12 years, at least 4 TMS devices have been approved in the US. One of these, the Brainsway, was for deep TMS. The first one has been NeuroStar, then Maxim and Adventure. And this was very important because we need to consider that having this approval for major depression had some important consequences in terms of reimbursement. You know, the systems in the US is totally different, for instance, compared to the system we have in Italy or in other European countries. There you have Medicaid and Medicare. So knowing that these insurances companies can provide reimbursement for these techniques, of course, is a totally different scenario. And you have a lot of clinics and private clinics as well offering these services under this approval. The situation, unfortunately, is not at the same level in many other European countries, in Italy, but we also have several other countries like Canada, Brazil, Australia, that also received a specific approval for the use of specific devices in patients with major depressions and also most recently OCD. Now, again, the large number of studies with TMS actually led to the publication of the first evidence-based guidelines. Here you have the update of probably one of the, I would say, more complete guidelines that are published in Clinical Neurophysiology by an international panel of experts. And these guidelines actually do not just take into consideration depressive disorders, but I would say the entire range of neuropsychiatric disorders, so also neurological condition. These guidelines here, I don't know if you can follow the full screen now, have been published in 2016 by the CANMAT networks. And what is interesting from these guidelines is that they made a comparison between TMS and other techniques, other brain stimulation techniques for patients with major depressive disorder, considering acute efficacy, maintenance efficacy, and safety and tolerability. And as you can see here, rTMS was rated with a level 1 in terms of acute efficacy, better or at the same level of ECT, but better compared to other brain stimulation techniques. Also level 1 in terms of safety and tolerability, and level 3 in terms of maintenance efficacy. This is a field in which we need additional data. You can hear me, Stefano and Anna? Can I keep on talking?
Yes, we can hear you. You can go on. Thank you.
Okay, thank you. Now, in order to get a closer look to the major depression field and to the clinical messages that have been delivered over the last years, I think that this document here, this article, this is a consensus review that was published in Brain Stimulation in 2016, mostly by a panel of North American experts, exactly in the field of major depression, with a series of recommendations about what could be the optimal treatment and indications for TMS in patients with major depression. So you can see here the first recommendation: TMS therapy is recommended as an acute treatment for symptomatic relief of depression. Recommendation 2, TMS therapy is recommended for use as a subsequent option in patients who previously benefited from an acute treatment course and are experiencing a recurrence. So as it happens with antidepressants, if you previously responded to TMS, there is a higher likelihood that you can respond again in case of a recurrence. Recommendation 3, TMS therapy can be delivered with or without the concomitant administration of antidepressants or other psychotropic medications. Now, in my experience, apart from some randomized controlled trials that understandably need to avoid any confounders, the use of concomitant antidepressant is considered the rule rather than the exception in clinical practice with TMS. Recommendation 4, TMS therapy can be used as a continuation or maintenance treatment for patients who showed a previous benefit with acute TMS. And last recommendation, TMS therapy can be reintroduced in patients who are relapsing into depression after initially responding to TMS treatment. So, you know, the concept of relapse is different from the concept of recurrence. So what was important for me in this set of recommendations is that authors also recommended positively the maintenance and continuation of TMS beyond the acute phase. But a problem with that is that we don't have really so many studies leading clinicians and giving them clues on how implement continuation protocols. Now, this has been another interesting study, again from a panel of North American experts. This was published in Depression and Anxiety in 2016. And in this study, what authors did was to pool 11 clinical trials, and you can see here more than 1,100 patients, in order to assess the pattern of response to TMS, the rate of response, and the rate of remission, also including potential predictors of response in terms of the socio-demographic and clinical variables. And their results show that the response-associated peak was at 57% reduction in depression rating scores. So this is what we can expect in terms of response. Almost 60% reduction of rating scale scores. 46%, so a little less than half of patients met response criteria, and almost 1/3 remission, which I believe are very positive data. Now, in terms of predictors of response, authors noted that a greater likelihood of response was observed for patients with less severe depression at baseline. Again, what I was trying to stress before. So those with a lower also level of resistance, which is a concept closely related to the severity of illness. Also a shorter duration of the current episode, and a recurrent rather than a single episode of depression. Also, a higher response was observed in patients treated at higher stimulation intensities. This has been another important meta-analysis published recently in the JAMA Psychiatry. This was published actually in 2017 by Andre Brunoni and colleagues. And they wanted, with this network meta-analysis, to assess the efficacy and acceptability of different modalities of rTMS used for patients with major depression. So they excluded trials with less than 10 sessions, and they could identify more than 80 studies with more than 4,000 patients, mostly women, and interventions that were found to be more effective compared to sham stimulation were priming low-frequency TMS, bilateral TMS, high-frequency TMS, theta burst stimulation, and low-frequency rTMS. In this study, some new TMS protocols, including accelerated TMS, synchronized TMS, and deep TMS, at that time resulted to be no more effective than sham. But some recent studies actually reported different results, which we are going to surely review in a while. And so the conclusion of this meta-analysis was that, in particular, priming low frequency, which actually is not very popular in many clinics that use TMS, but this was the results, and bilateral rTMS, which on the other hand is used pretty much in clinical practice, were the most efficacious and acceptable interventions among all the various modalities of TMS for patients with major depression. This is another important review on the argument. This was published 1 year after the previous one in 2018, Neuroscience and Biobehavioral Reviews. You can see, again, a really high number of studies included. Authors in this case were not just focusing on TMS, but also on TDCS and theta burst stimulation. They were looking for sham-controlled, randomized controlled trials, and in this case, without initiation of other treatment like antidepressants. And actually, probably they reported results that are more that are closer to clinical practice in terms that the high frequency TMS over the left dorsolateral prefrontal cortex was probably the most effective technique compared to many others that also were more effective than sham treatment, but not as effective as high frequency rTMS. Of course, intermittent theta burst stimulation was able to provide an important advance in terms of reduced treatment duration, but we are going to comment on that in a few slides. Now, let me probably give you a little bit of history in terms of what happened since the previous years of research in the field of TMS in major depression, and where did we arrive in the last years. So I'm going to talk a little bit about these four issues here: duration of trial, high versus low frequency, navigated TMS, and other stimulation parameters. Now, in terms of duration of trial, we said that now we consider that the standard duration of a traditional TMS trial is 4 weeks. And actually, if we look to the early meta-analysis on the efficacy of TMS, like this one that was published in the British Journal of Psychiatry in 2003, you can see here that the results were not positive, were negative. So you can read TMS efficacy yet to be established. So this meta-analysis had included 14 controlled trials, and authors had negative results in terms of efficacy in patients with major depression in particular. So what happened? In this other meta-analysis here that was published actually 4 years later in the Acta Psychiatrica, you can read the title, has repetitive transcranial magnetic stimulation treatment for depression improved? So what happened? And others actually could point out that more recent trials with rTMS had shown a larger antidepressant effect compared with the previous studies. And this was probably due to the fact that more recent trials had used novel parameters, and in particular, more sessions of rTMS. So 10 sessions, 2 weeks of TMS, which was the standard in the first 2,000 years, actually was challenged with the notion that at least 4 weeks of TMS duration were necessary to produce a significant effect. This has been probably one of the two most important trials published in the field of TMS that actually led to the FDA approval. So this was a multi-site American trial, was published first name Riordan in 2007 in Biological Psychiatry, and you can read here some of the most important features of the sample. 301 medication-free outpatients, so these guys were not taking any antidepressants, with major depressive disorder, who had no benefit from previous treatment, were treated with 4 to 6 weeks of TMS, high frequency, 10 Hertz, 120% of the Mothers threshold, and a total amount of 3,000 impulses per session, which meant per day, on the left dorsolateral prefrontal cortex. And what was clear from authors' results is what you can see here in this figure. So at 2 weeks, you could not reach a difference, a statistically significant difference from placebo, from sham TMS, which you could starting week 4 onward. So message was you need at least 4 weeks to and more to produce a sustained and robust and particularly a statistically significant improvement versus sham stimulation in patients with major depression. This was the other important study. This was published by Mark Judge and colleagues. Was a multi-site trial as well. The methodology actually was very similar to the previous one. It was published at the Archives of General Psychiatry in 2010. You can see here almost 200 antidepressant drug-free patients, same area, non-psychotic. This is another important characteristic to stress here. Were treated with TMS, left dorsolateral prefrontal cortex, same parameters, 120% motor threshold, 10 Hertz for second train duration, and 26-second intertrain interval for an overall duration of almost 40 minutes and 3,000 pulses per session with an 8-figure coil. So results showed that there was a pretty high retention rate. You can see almost 90% without differences between sham and active TMS. And this was the most important results. So a difference in terms of remitters between active TMS and sham, 14% with active and 5% with sham. The odds of attaining remission were more than 4 times greater with active versus sham TMS. The number needed to treat with TMS was 12. Now we know that number needed to treat should be in single-digit number, but let's say that 12 is pretty good. Is acceptable, particularly because. In this trial, and I think that this was the most important message from this study, authors had also included a certain rate of patients with TRD, with treatment-resistant depression. And what they found was that the majority of remitters to active TMS had actually low antidepressant treatment-resistant level. And I think that this is another very important issue to stress here. So back in those years, in this article, our take-home message was that the longer 3 to 4 weeks the patient could stay in treatment with TMS, the higher was expected to be the improvement rate. And also, the higher the level of treatment resistance exhibited by the patients, the lower the response rate. Actually, in those same years, because this article was published in 2010 in Depression and Anxiety, the concept about the overall duration of treatment, particularly in terms of weeks of stimulation, started to be somehow challenged in that, as you can see here, authors used a very aggressive protocol of accelerated TMS, which means 15 sessions administered over 2 days, with, of course, the benefit that you can reduce the overall duration from 4 weeks or 3 weeks, if we are talking about doing 1 session per day, traditionally from Monday to Friday, and you concentrate the 15 sessions over 2 days. So this was a positive study at that time, and very recently, we had a new report in the field of accelerated TMS, which personally I believe is a very important and interesting perspective from a clinical point of view, trying to reduce the overall duration of a TMS trial with a standard TMS device. So I was saying that this was published a few months ago, and in this article, authors identified 11 studies, and 3 of these 11 studies were randomized controlled trials using actually different protocols of accelerated TMS, not an aggressive protocol like the one of the previous studies, but they had positive results showing that accelerated TMS was actually able, particularly focusing on randomized clinical trials, to produce statistically significant improvements compared to sham in terms of depressive symptom reduction. And probably I think that this is, we are also now starting in our university hospital a trial of accelerated TMS, because, you know, requiring a patient to remain in treatment from Monday to Friday for weeks. Of course, we know that there are no biological reasons for, of course, avoiding to deliver the treatment on the weekend. This is just for clinicians, right? And so having an overall duration of 20 days, of 4 weeks, can be challenging for many patients. And so probably trying to reduce the overall duration, of course, maintaining a high standard of safety is very important. Now, in terms of high versus low frequency, we have some meta-analysis here as well. I'm just trying to go a little faster on this. Let's say that the majority of trials and meta-analysis did not point out a difference, but probably in terms of discomfort for a patient is better to receive low-frequency TMS compared to high-frequency TMS. We had an experience in this regard in this study published in European Psychiatry in 2015, and we used actually 3 different protocols of TMS: low frequency continuous, low frequency intermittent, and high frequency intermittent. And we also could not find any difference in terms of superior efficacy among these 3 different protocols. So there is some literature recommending high frequency as likely the most effective, but it's also true that probably low frequency is more comfortable for patients, and so probably it makes sense. It would make sense to start with low frequency and then go to high frequency in case of non-response for patients who are particularly vulnerable to the discomfort produced by high-frequency TMS. In terms of navigated TMS, I heard from Professor Palanti that you probably had some lectures yesterday on the topic, or you are going to talk again about this today. And let me just saying here that traditionally, in order to identify the resting motor threshold, which is different for every candidate patients to TMS, operators first detect the motor cortex area by delivering a series of single impulses and look for contralateral movements of the thumb. Then, following the 5 centimeters rule, they move on the anterior line to the front for 5 centimeters, though some authors believe that 7 centimeters would be more appropriate to spot the right, the correct, dorsolateral prefrontal cortex. Now, even though this area is a pretty large spot, it is easily understandable that this procedure is less precise and reproducible. Generally, operators make patients wear a swim cap in which they mark the different spots, but of course is definitely less precise and reproducible than using neuronavigation. And in fact, there is a series of studies showing that the precision of neuronavigated TMS is larger compared to non-navigated TMS, but this is an experience that we had in 2009 with neuronavigation system. This study was conducted in patients with bipolar depression, and we could use a neuronavigation system collaborating with our colleagues from neurophysiology unit. Of course, you need to obtain first an MRI of the patients, and the overall cost of the procedure are understandably higher. So my personal view in this is that probably using neuronavigation as a standard is with TMS is certainly a plus, but probably is more suitable for research setting than for a routine outpatients units. We have also other stimulation parameters that need to be taken into consideration. An important one is considered by the coil shape and field distribution. Here you can see the difference between a classical or traditional round coil and an 8-figure coil. With a traditional coil, we know that the depth of penetration of TMS is at 2 to 3 centimeters, typically at the junction between gray and white matter. And I know that you are going to talk about deep TMS, and you probably already heard something about this topic from previous lectures, and you know that the advantage of deep TMS, which was approved by the FDA in 2013, is that you can reach deeper regions, particularly at the level of the limbic systems, and also reduce a little bit the overall duration of TMS of the trial. So at that time, in this article published in Journal of Affective Disorders in 2015, 9 studies were selected. And let's say that deep TMS has always had a connotation of more suitability for treatment-resistant patients, and actually results mainly coming from open-label studies at the time were positive, but also showed that concomitant treatment with antidepressant was able to enhance the efficacy of deep TMS. Now, there has been a very, very recent update in the field. This was published in Progress in Neuropsychopharmacology and Biological Psychiatry, really a few weeks ago. And you can see this comes mainly from a multi-site Asian panel of experts. And authors now, compared to the previous article of 2015, could actually identify 15 studies, including also 3 randomized control trials and 12 uncontrolled clinical trials. And you can see here that they found that deep TMS significantly improved depressive and anxious symptoms in patients with treatment-resistant depression. The non-randomized controlled trials had a larger effect compared to the randomized controlled trials. And what, again, is important for us to stress is that only studies using both TMS, deep TMS, and antidepressants were able to achieve statistical significance. Another important thing is that tolerability, the profile of tolerability was favorable. So also stressing the fact that deep TMS is safe, because first studies with deep TMS, particularly studies from the clinical neurophysiology perspective, like this one published in 2014, with also Sarah Lisenby among authors, actually pointed out that there was some concern. So you had to be more careful using deep TMS, particularly at depths of 4 centimeters or more, because particularly when going beyond 6 centimeters, the procedure was unsafe because of an excessive superficial stimulation strength. And actually, from the previous studies on deep TMS with new parameters, it looks like the procedure is totally safe and effective. Now, in terms of future perspective, let me move to the last slide of my talk here. Certainly, patterned TMS, which includes, for instance, theta burst stimulation, is one of the most interesting evolutions of TMS for many reasons. First of all, the standard theta burst pattern consists of 3 bursts of pulses delivered at 50 Hertz and repeated every 200 milliseconds. And actually, you can deliver with this method a huge number of stimuli in a few minutes. And this will allow to save a considerable amount of time, moving from the traditional 30 to 40 minutes of a standard session of TMS to 3 to 4 minutes. So you can, of course, treat many more patients than with traditional TMS. Of course, we have also in this field a lot of meta-analysis. This has been one of the most recently published in the Journal of Psychiatric Research 3 years ago. I'm going just to shortly stress the fact that the results here were positive, particularly in terms of response in theta burst stimulation, in active theta burst stimulation compared to sham theta burst stimulation. Here you can see the different rates of response from almost 36% to 70.5% in the 2 groups. And again, the procedure was found to be safe. Now, if we want to try to extrapolate some take-home message, particularly in terms of high frequency TMS, which probably still is one of the most widely used parameters and protocols of TMS. In this article published in 2007 in European Psychiatry, authors tried to see what was the optimal standard in terms of a number of stimuli provided per session. And they included 30 randomized controlled trials, a lot of patients, as you can see here. And first result, the effect size, of course, was larger when they analyzed studies from using 5 up to 20 sessions of TMS. So again, a higher number means a higher success in terms of efficacy. And the other very important results was this one. Probably the optimal number of pulses when using high frequency or TMS is included between 12 and 1500 of stimuli per day. Now, among the other evolution, I hope you can follow me in full screen, is the use of TMS in pregnancy. Because you know the limitations with antidepressants and the reluctance that many pregnant patients with depression have toward antidepressants. And so TMS, lacking systemic effects and most importantly, avoiding effects on the fetus, can be a very suitable intervention for pregnant women with major depression. This was one of the first reports published in 2016, also at that time able to analyze 12 articles, and results were positive, because authors were pointing out that remissions was frequently achieved in many cases, and that the procedure was well tolerated, and there were no reports of damage and complication to children. So this has been probably the latest update in the field, and I wanted to just mention this study because this is one of the most important randomized controlled trial in the field of TMS in pregnant women with MDD. It was published in Brain Stimulation in 2019, and here subject received 20 sessions of TMS to the right dorsolateral prefrontal cortex at 1 Hz, so it was on the right side with low frequency. I would say a slightly lower amount of pulses, 900 pulses per session, and the 100% motor threshold. And actually, others found positive results. They included 11 patients randomized to active TMS and 11 to sham TMS. So is a short sample, is a limited sample study, but results in terms of Hamilton Depression Rating Scale showed that the active TMS was more effective than sham TMS, and they had a response rate of more than 80% for active TMS versus 45% for the sham TMS. So I think that this is also another important procedure. The real last thing I'm going to talk about is related to the maintenance of effect, because this has been somehow a neglected field. There are two main questions, at least in our experience. So I'm going to briefly show, before concluding, two studies of my group in this regard. Two questions. First of all, what happens when you interrupt, when you finish, when you complete the acute trials of 4 weeks? This is actually the follow-up of the previous study I showed you before in bipolar depression. So in this study, 11 patients entered a naturalistic follow-up with evaluation every month up to 1 year. And what we found, but the sample was limited just to 11 patients, is that if patients achieved remission after acute TMS, this was predictive of maintenance of response without doing any maintenance session, just maintaining the acute response shown at the end of the acute trial, also for the following year. On the other hand, the absence of acute or TMS response predict the absence of subsequent response in the long term. And this is actually our latest study in the field, which we have just submitted. And this study included 31 drug-resistant patients. Actually, these are the patients who completed the other trial I have shown you before with 3 different protocols of TMS, low and high frequency. And these patients entered another follow-up for 6 months with 3 time points, assessed again with the Hamilton, and in this case also with the Young Mania, because we know that some bipolar patients were also part of the sample. And our main results here was actually a little different from the previous study, because we found that there was a higher rate also of late responders. So patients who you can see here after the end of the 4th weeks had a response. So had a late response even after the acute treatment was finished. And that there was a higher rate of late responders among previously acute TMS non-responders compared to the rate of relapse among those who had acutely respond, so which was 10%. So in other terms, there was a larger rate of patients with late response than patients with early relapse or after having previously responded. And I think that this is another important result, because overall we had a 90% response maintenance, and you know that there has been a lot of debate in terms of the duration of the TMS effect, comparing TMS with ECT. Now, the last study I'm going to show you is this one published with some collaborators, Gianluca Serafini, leading author here, and the article is in Press in Progress in Neuropsychopharmacology and Biological Psychiatry, and this is specifically referred to suicidal behavior. So we know that this is one of the most important things in patients with depressive disorders, unipolar and bipolar, and there has been a lot of debate whether TMS was effective in terms of suicidal ideation and suicidal behaviors directly or indirectly after some effect on mood. So in this study, so in other terms, if TMS can have a specific anti-suicidal activity like lithium, for instance, and in this article here, 16 reports were identified, in particular 7 sham control studies, and among the results, again, the dorsolateral prefrontal cortex was identified as the most frequent stimulation target. And actually, TMS, particularly in these two methodologies, bilateral TMS and TMS in combination with antidepressants, showed a specifically anti-suicidal effect. So here I come to my conclusion. The TMS is certainly considered the brain stimulation technique that showed the larger development in the field of clinical psychiatry and major depression in particular. Probably in light of its favorable tolerability, TMS and also TDCS are the most widely used non-invasive brain stimulation at present time. We know that large sample randomized controlled trials indicated that patients with poor to partial response to standard antidepressants are likely the best candidates for TMS when they are treated for at least 4 weeks. We have meta-analysis and international guidelines to support the efficacy of TMS in major depression, with also some evidence in other fields like addictions. And recent research and guidelines is providing new evidence for optimal setting parameters for TMS in major depression. And in conclusion, I just want to thank you for the attention, in particular Professor Palanti, his collaborators, the ACMP, and for those of you who are interested not only to TMS, but also to the entire area or non-invasive brain stimulation, this Springer volume edited by me and Giorgio Di Lorenzo, and containing also contributions from Professor Palanti, from Professor Martinotti, and other invited experts in this faculty, will be available in the next few weeks. So thanks for the attention.
Okay, thank you very much, Leonardo, for this very important educational presentation about TMS in depression. Yesterday we were at the conclusion, we were talking about how large is the possibility to get TMS for obsessive-compulsive resistant patients. According to recent finding, apparently less than 0.2% of resistant OCD can receive TMS. What's your assessment about in depression, resistant depression?
Well, Stefano, my point here is what I was mentioning about the FDA approval. So, of course, I can talk to you about the situation in Italy because it's the one I am more familiar with. And here, a big problem is related to the need, particularly in public institutions like the one we're working with, to get ethical committee approval. There's a lot of bureaucracy. Of course, you need to find some funds, some research funds, in order to justify this treatment in the public. So certainly this eventually produces a much lower rate of patients who are treated, who are exposed to the possibility to receive TMS compared to the what would be the real rate of patients. And what happens to these patients? These patients move to private institutions. In many private institutions, they can find a very high standard. But of course, I would say that overall, the institutions that can provide the facilities that can provide TMS for depression, and I'm talking about, I would say, a big reality like the city of Milan, are still very, very, very limited.
Okay, thank you so much. So, are there any question of the chat for?
Let's see.
So the paper is open, so we have some time.
So if anyone has some questions, please write it down in chat. Ok.
Ci sono delle questioni.
Queste sono di prima perché era saltato.
Non ci sono. Are there any questions? Non ci sono. No one. Okay, no any further question. It was crystal clear representation, so maybe we can have some room at the end of the following session for a broader discussion. Okay, thank you once again, Bernardo, for this brilliant presentation. Let me introduce Professor Giovanni Martinotti, that is Associate Professor of Psychiatry, Department of Neuroscience, Imaging and Clinical Science at University Gabriele D'Annunzio di Chieti. And he's also Visiting Professor at University of Hertfordshire in UK, Unit of Pharmacy and Addiction. And I'm very pleased and thankful to Professor Martinotti for being here today, and I will listen with a great attention. Thank you, Giovanni.
Professor Martinotti is Associate Professor at the Department of Neuroscience, Imaging and Clinical Science at University G. D'Annunzio, Chieti Pescara, Italy, and Visiting Professor at the Department of Pharmacy, Pharmacology and Clinical Science, University at Hertfordshire, Herts, UK.
Yes, I can see it. Thank you very much, Stefano, for this opportunity and to participate in this very relevant meeting. I'm trying to upload my presentation. Let me have a look. Can you see something?
Okay, it's working.
Yeah.
Good. Now, the topic of my talk will be about transcranial magnetic stimulation and transcranial direct current stimulation in substance addiction. This is a very large field, and I can see a new field of use of these brain stimulation techniques. So I'm going to try to give a general picture of the situation. And this is the agenda of my talk. We are going to speak about TMS and TDCS with the operative principles. Then we are going to look at the rationale of use of neuromodulation in substance use disorder. We will focus our attention on the TMS use in substance use disorders with a specific focus on cocaine use disorder. Then we will move to TDCS use in substance use disorders, also trying to emphasize the possible side effects of these techniques in substance use disorders. And then we will speak finally about the future perspectives of these two techniques.
Giovanni, sorry, I don't know if you have tried to move your slides, but we are stuck on the first, so we can see them moving.
Bizarre. Why?
We can see the whole screen, but as before for Bernardo, it was only on the first slide.
Tell me if something is moving, yeah?
Okay, now no screen, only your webcam.
Allora, I'm trying to upload it again because
Okay.
it's very unusual.
Okay, so okay.
Now, allora, now you can see the first slide.
Yes.
And can you see the second one?
Yes.
Okay, I leave it in this way also if this is not in the full screen, but I think that is possible to see it.
It's
Probably.
okay, of course. Of course. Thank you.
So this is the agenda of my presentation, my talk. And of course, I'm not going in details about the specific principle of neurostimulation and neuromodulation, but I would like to focus the attention on a specific topic, because we know for sure that the magnetic field decays rapidly as a function of the distance from the coil. The reason why I'm saying this is, of course, because if you're going during this talk to speak about substance abuse and the most important rules of the addiction, we know for sure that nucleus accumbens is the area where all the addictive substances are working in some way. So for sure we are not going directly to that specific place, but with the TMS, for example, we are reaching the first centimeters of the cerebral cortex, and of course, in order to understand what we are going to do, we need to take into account this very relevant aspect. And of course, we have different possible action. We have a direct action with the electrical variation induced by the magnetic field on all the neural elements. We're speaking about axons and dendrites. And then we have the transsynaptic activation with the activation of the pyramidal cells of the cortical between the different systems in our brain. One of the main issues with the transcranial magnetic stimulation is that of parameters. This is because we have, as you have seen in the previous presentation, we have different possible protocols with the high and low frequency stimulation with the different number of impulses. We have different coils. Then we can speak about right, left, or bilateral stimulation with or without psychosocial and pharmacological interventions. The role of parameters is very relevant, and this is probably one of the main aspects that is correlated with a non-specific effect in terms of superiority to sham effects with these specific techniques. Something more about TDCS, which is a non-invasive method of brain stimulation intensively investigated in clinical and cognitive neuroscience in the last 5 years. The general impression about TDCS is that it's a safe technique with mild and transient adverse effects. These are the good point of this technique. In fact, TDCS is a useful intervention for a lot of neuropsychiatric disorders, combining interesting features such as non-invasiveness, low cost, easy of use, and powerful effects on cortical excitability. With the electric fields used in TDCS, we can see subthreshold perturbations, which means that TDCS is not intended to cause single neuronal depolarization, but to influence the communication between individual neuron and complex neuron network. Therefore, in this way, also a small change in brain-brain tension can affect neural transmission. When we are working with the TDCS, with direct current stimulation, we know trying to look it in a translational way, we have a cathodic stimulation able to reduce the glutamatergic activity, while the anodic stimulation is able to reduce the GABAergic activity. This is important in order to understand what we are doing also in the perspective of substance use disorders. Of course, also for TDCS, we have the issue of parameters, because we have different amperages. The stimulation time is also very relevant, with stimulation starting from 10 minutes, reaching 30 minutes, 40 minutes stimulation time. The electrode positioning, the right, left, bilateral stimulation, and of course, also with the TDCS, the presence or absence of psychosocial and pharmacological intervention. As you can see, the issue of parameters is probably the most important thing that we have to consider. Which is the rationale of use of neuromodulation, brain stimulation techniques in substance use disorders? Let's try to start with this example. We have a horse and we have a horse rider, and the horse can be considered as the specific effect of substances. Here we are doing the example of cocaine that can increase the activity in the circuits of reward, motivation, and memory. The substance, like a horse, is trying to stimulate the nuclear accumbens and all the related circuits. And then we have the horse rider, that in some way is the cognitive control that we have on the horse, that we have on the lower structures, that we have on the nuclear accumbens system. So in some way, we need to decide if trying to give our treatment effects directly on the horse, on the basic structures, or trying to treat the horse rider in this way, and saying that we also have possibly we also have to treat the cognitive control, and in some way the cortex. So we have two different approaches to calm down the horse, reducing activity in the limbic arousal loop. We can do this with low frequency RTMS or continuous theta bar stimulation of the ventromedial prefrontal cortex, or to increase the horse rider strength. In this way, we are trying to increase the activity in the executive control. And in this way, we are speaking about high frequency RTMS or intermittent theta burst stimulation. So two different approaches. The group of Colleen, Hanlon, the United States is specifically working on the first network, and our group in Italy is working on the executive control. So we are trying to improve the control of the horse rider, and the Hanlon group, they are trying to reduce the activity of the horse. Of course, I can report the activity of our group, saying that the reason why we are trying to look at this specific target, which is the dorsolateral prefrontal cortex, because we are trying to work on the dimension of impulsivity, the willingness to take risks, and also the decision-making processes. Of course, these decision-making processes in addiction can be modulated, enhancing inhibitory control. which may lead to a reduction in the use of substances using high frequency pulses with TMS. Or in some way, also if we want to speak about TDCS with the anodal stimulation of the TDCS in that specific area. This treatment, specifically with drug-addicted subjects, could increase dorsolateral prefrontal cortex functioning, implementing the possibility to control craving. So, in this way, we are not going to eliminate, to extinct craving. Probably craving is going to be more or less the same, but we are improving the way the patient is controlling his craving. This is a relevant point. But we also have to speak about brain plasticity, because we have different preclinical studies that have clearly demonstrated that RTMS and also TDCS induce long-term potentiation, for example, that are strictly dependent on NMDA and EMPA receptor signaling. In which way is possible to produce these brain plasticity effects? By increasing the intracellular concentration of calcium and modulating the excitability of subcortical glutamatory pyramidal neurons and inhibiting the release of gamma amino acid. And also, we also have some studies saying that BDNF, which is a neurotrophin, is essential for delayed effects of cortical stimulation. So, apart from the direct effects on the different areas, dorsolateral prefrontal cortex, medial prefrontal cortex, and so on, we have also a specific effect on brain plasticity. And trying to give a look at the reason why we have different possibility in the field of substance use disorder, we know that at the moment the best level of effectiveness of RTMS is in the treatment of nicotine and stimulant use disorder. Also, in this case, most of the trials are about dorsolateral prefrontal cortex, even if also the other possibility that of the studies of Allon and collaborators, a possible effect on medial prefrontal cortex and ventral striatum may also be considered as a feasible and fruitful target to be considered. But in order to understand why brain stimulation techniques had these specific developments in the area of substance use disorder, we have to go back to the study of Antonello Bonci on rats dependent on cocaine treated with the optogenetic. With these techniques, we can see that grafting an optical fiber connected to a diode capable of reaching such sensitized neurons, they obtained a specific stimulation by light beam, influencing the dopaminergic activity. But before giving this specific stimulation by light beam by these optical fibers, we need to understand which is the specific kind of population of rats that they selected, because at the beginning they decided to select a specific population of rats addicted to cocaine after an induction period. Then they started to induce foot shocks in order to decrease the lever press, because in order to induce a population of cocaine rats, addicted rats, of course you need in the experimental model to produce a specific cocaine release after the specific press of a sick lever. So the rat is pressing this lever in order to obtain, for example, food, water, and substances, in this case cocaine. So this is the way to induce a specific population of rats addicted to cocaine. But then they also put the possibility to have a specific electric shock after pressing this lever. In this way, they obtained a specific population of rat that also, if they received a specific shock after the lever press, they continued to press the lever in order to obtain cocaine. So they obtain a specific population of rats shock lever resistant. In this way, this is a very useful situation, because in clinical practice we can see that let's go to speak about cocaine patients. Cocaine patients are in some way resistant patients, because they are continuing to use cocaine also if they are experiencing many issues in the area of their family environment, in the area of legal affairs, in the area of working positions and so on. And this group of cocaine subject resistant to the use of cocaine is in some way comparable to this population of cocaine addict rats. And after the specific induction of this rat population, they start with the optogenetic treatment with a specific electrode posed in their medial prefrontal cortex. And they obtained very specific behavioral changes in dependent rats between the baseline evaluation and after the optogenetic treatment. So in this way, we can translate this optogenetic example to what the TMS can exert on the dorsolateral prefrontal cortex. Of course, for sure, we cannot compare our brain system with that of a rat, but in some way is a possible translation. And of course, TMS is not a direct optogenetic shock on the medial prefrontal cortex, but the results of the Antonello Bonci's studies were really strong in terms of cocaine reduction in the rat model. So this was the rationale that prompted the research directly into the area of substance use disorders. Of course, at the beginning, we had different studies on cocaine addiction, mostly because these studies of Antonello Bonci regarded the use of cocaine, but we have possibility also about other specific substances. And we know that from 2007 we have different studies with small samples, and most of them are open studies with the stimulation of the dorsolateral prefrontal cortex, apart from the study of Colleen Hanlon on the medial prefrontal cortex. Most of these studies were made with the figure of 8 coil, apart from the study of Bolloni with the H coil, with the deep transcranial magnetic stimulation. And apart from the study of Hanlon, we have high-frequency TMS, while in the Hanlon study we have the continuous theta burst stimulation. So you can see different possible parameters, different frequencies, and also different results. But more or less, we can say that most of the results were positive. But again, we have to emphasize that all these studies were open studies, and also our contribution to the field is about open studies about the use of transcranial magnetic stimulation, and in these studies we observed an improvement specifically in the symptoms of anhedonia. And we know that anhedonia is a symptom that is strictly connected to the use of substances, because of course we are speaking about the pleasure of a mechanism, the mechanism of pleasure. And so it is important, it was important to observe in our study a specific effect on the anhedonic symptoms. Also because if we are going to improve the hedonic tone, for sure we are going to reduce the craving for cocaine. And to this respect, our results were encouraging. As you can see in this slide, we have effects on the TEPS score, which is a specific scale for anhedonia, as well as a specific effect on the visual analog scale for pleasure. However, as I have emphasized, we have to consider that most of these studies were open studies. And when we are speaking about TMS and when we are speaking about devices, the role of placebo can be very, very strong. There's a relevant literature about the strength of the placebo effect when we are using devices. We have also very interesting studies about the comparison between the placebo effects in the classical drugs studies about, for example, placebo-controlled trial about antidepressants and so on, in comparison with the placebo effect exerted by devices. So without a double-blind placebo-controlled study, I do think that we cannot reach a specific conclusion about the use of these specific techniques. And in order to clarify these aspects, we decided to run a specific double-blind study about TMS for cocaine addiction with a very specific experimental design with an intensive RTMS phase with 2 sessions per day for 10 days. Then RTMS follow-up phase with 2 sessions per week for 12 weeks. And then a follow-up with no RTMS stimulation. This is because we can say was because we ended this trial some months ago. It's a randomized, controlled, double-blind study with a stimulation with 15 Hz, 100% of the motor threshold with 2,400 pulses, 60 pulses per train, 40 trains. And this study was neuronavigated, and of course we could have a specific comparison between RTMS and sham. We also had a neuropsychiatric assessment of our patients and a specific neurophysiology branch, trying to see other aspects. We are going to present and publish the results of this study in the near future, and I can say that we have interesting results, but the issue of placebo, the issue of sham is something that is quite relevant. And probably in future study we have to say that specific run-in procedures in order to understand which subject, which patient is more sensitive to placebo could help to understand and to clarify the effect of these techniques. These are the characteristics of our sample. We can see that more or less are in line with the the demographic characteristics of the substance, the classical cocaine addicts in Italy. And in our population, we also had subjects smoking cocaine and doing heavy absorption of cocaine, so quite severe population of subjects. But moving forward, let's look at other possibility of use of TMS. For example, in alcohol use disorders, we have some trials. The first study about RTMS treatment of alcohol dependence studied the anti-craving efficacy of 10 Hz high-frequency RTMS stimulation of the right, not the left, the right, dorsolateral prefrontal cortex in a single-blind sham control study in 45 patients. It was found that 10 daily sessions of high-frequency RTMS over the right dorsolateral prefrontal cortex had significant anti-craving effects. Why the right and not the left dorsolateral prefrontal cortex? I don't have a specific answer to this question, but it's important to emphasize that the question of parameters is the determinant topic in order to understand if brain stimulation techniques are useful or not in substance use disorders. Also, we have other studies about alcohol use disorders in other areas, for example, focusing on the dorsal anterior cingulate cortex. And we have another interesting study about made by the group of Giovanni Addolorato about deep TMS and SPECT evaluation after 4 weeks of RTMS sessions. In this study, they observed that patients receiving the real stimulation revealed a reduction in that availability at T1, whereas the sham-treated group did not suggest a modulatory effects of deep RTMS. So we can see that here we have a specific neurobiological effects. Also, if in this study a specific efficacy effect was not evidenced, probably because they had a low number of participants. Probably the most relevant data about TMS and substance use disorders are in the area of nicotine use disorder. For example, this study of Johan, a collaborator, investigator, whether RTMS of the dorsolateral prefrontal cortex could modulate the level of tobacco craving. And they observed that RTMS significantly reduced the level of tobacco craving reported 30 minutes following the treatment. We also have other study with deep TMS focusing on the prefrontal cortex and the insula bilaterally. Also here we have positive results. But let's move to TDCS stimulation. Some years ago, we published this review about the role of TDCS in substance use disorders. And we could see that we have at the moment different studies, limited in the number of participants, not more than 50 subjects. Most of the data are related to open studies without a control, without a double-blind setting. And we have different protocol and very different stimulation procedures. However, recent results showed that TDCS stimulation was effective in reduction of craving in 8 of 16 clinical trials over the dorsolateral prefrontal cortex, and in 1 of 2 clinical trials over the frontoparietal temporal cortex. So, in this way, we know that we have possibilities and worthy of going further to the use of this technique in substance use disorder. For example, we proposed this double-blind design open to different kind of substances like cocaine, opioids, alcohol use disorder, cannabis, gambling disorder as well. And in this study, we observed an improvement in the level of craving, but also in the level of, for example, depression and anxiety as to the Hamilton depression and the Hamilton anxiety, but also in the level of impulsiveness as to the Barrett impulsiveness scale. So although the group of users in our study was really heterogeneous, we have observed some effects, and this is a good point to start with. Looking at specific substances, we have this study of Gorini saying that in the treatment of cocaine addicts, it's possible to see a good effect with a 1.5 milliampere stimulation of 20 minutes. And so we have this ground to go further with this study about substance use disorder. Also because we have a specific contribution of about neuroimaging correlates of these effects. Probably the most relevant area where we have results with DCS is that of alcohol use disorders. If alcohol use disorders is an area where the studies with TMS are not satisfactory, with DCS probably we have more data. In my clinical practice, for example, with the alcohol with the alcoholics, if I have to decide if using TMS or TDCS, I'm choosing to use the TDCS. Probably this is because the possibility of TDCS of reaching other specific areas that with TMS are difficult to reach, also reason of the specific centimeters depth of stimulation that we can reach with the TMS. So one of the most promising fields for the application of TDCS is that of alcohol dependence. This study on 13 patients, of course the number of patients is still limited, who received active anodal left cathodal right stimulation and active anodal right and cathodal left stimulation and stump stimulation with a set of current of 2 milliamperes for 20 minutes. This study showed a clear and significant reduction in alcohol craving in both the active group. And in these other studies, also for this is we can see an effect that was a long-lasting effect. After 3 months of follow-up, 72.2% of sham TDS group relapsed, whereas 72.7% of TDS group active stimulation remained abstinent. So, to this respect, we have also a long-lasting effect. We also have data about opiate use disorder, about 20 long-term heroin-addicted subjects that underwent single stimulation at 1 milliampere over frontal parietal temporal area with the electrode over the left or right frontal parietal temporal and anode over right or left orbitofrontal cortex. So, as you can see, we have in every study we have different parameters, different area of stimulation, and as I told you before, this is probably the main problem that we have at the moment. For example, if I'm giving an antidepressant to specific patient with major depression, I'm quite sure that I'm giving, for example, paroxetine. Of course, I can give paroxetine per os or by intravenous modalities, but the drug is that one, and probably we can change some parameters, but the heterogeneity is not so strong as we can see with the brain stimulation techniques. Another interesting area is that of cannabis use disorders. My clinical experience in this patient is really good, for example, but we also have studies and evidences saying that at 1 milliamperes, for example, for 10 minutes, we can observe some improvement, specifically with regard to risk task measures. Going to conclude, we can say something about safety. Of course, if we are speaking about addicted subjects, we have to bear in mind that to deliver the stimulation during the withdrawal phase can be dangerous because of the possibility to see some specific effects, for example, epileptic seizures. So it's very important to speak with the patient, to trying to do a critical evaluation of the withdrawal symptoms. And also the other possibility is that we have to avoid to stimulate a patient when he is intoxicated. So it's a good thing to do. A good thing to do is to do a specific toxicological analysis of the patient before the stimulation proceeds. But apart from this, the side effects that we observed during our trials, for example, with both TMS and TDCS, were really not remarkable, without any specific problem. In my experience, I never observed an epileptic seizure in a subject with substance use disorder stimulated with TMS, for example. But probably this is because we made a specific and careful evaluation of the situation of intoxication and the withdrawal. So bear in mind this aspect that can be very important. Then we have to consider, because it has been shown that patients with bipolar depression may develop post-treatment delusions of hypomania. So it's an issue that has to be taken into account, and we need to evaluate these symptoms also with the specific scales in this patient, also because the comorbidity between substance use disorders and bipolar depression and mood disorder in general is really high. So it's important to look at this aspect. Also, if I have to mention this study that we performed a couple of years ago, saying that the combination of neuromodulation technique and available pharmacotherapies is a valuable opportunity which is not undermined by specific effects of cortical excitability, and it could improve bipolar depression patient outcome. So neurostimulation technique may be considered safer than antidepressant treatment in bipolar disorder. So if we are also treating a patient with bipolar disorder and substance use disorder, in my opinion, the use of neuromodulation techniques is valuable and without any specific consequence. To conclude, which are the future perspectives? There's the growing need for pre-recorded online clinical trial and the sharing of protocol through interconnected platforms. We have many studies with small numbers, and we have to improve this aspect. Then it's very relevant a current selection of the study population. Actually, it's very important to take into account the ethnic differences, the comorbidities, the current therapies, and then the selection of a real patient. With cocaine use disorder, the heterogeneity of patients is really wide, so it's very important to focus the attention on a specific population in order to understand the real efficacy of a technique. There's the need for double-blind randomized controlled trials with a long follow-up period. It's important to use EEG and fMRI techniques to determine the variability of individual brain activity. And then it's important to look at endophenotypes of abusers, not only as regards substance, but also with regard to the specific typologies of craving. So we need to look at these aspects if in the future we really want to understand if brain stimulation techniques can help in this field that is very difficult. So we can say that in the meantime we have a good ground to say that brain stimulation technique can help in the treatment of substance use disorder, but we need to improve the studies, and we need to understand which is the good parameter, which is the good area, and there's a lot of work to do. But we have to say that in substance use disorders, the number of approved treatment is really low. So to see that we have possibilities with brain stimulation is saying that there's something very good that is possible to develop. And that's it. Thank you very much for your attention, and of course I'm available for questions.
I'm the only one clapping. Thank you, Giovanni. Very nice, very intriguing presentation. It's a very interesting opening field. The neuromodulation applied to addiction, I mean, and behavioral and substance. So if there is any question in the chat, can we check the chat?
Yes. Okay.
Okay.
Yes, we have one. Okay. One question. What are the perspectives for TMS and TDCS applications in polydrug use? Is there a recommended TMS, TDCS protocol for these patients?
An interesting question, because it's going to a very important point, because most, probably 80% of substance abusers are polysubstance abusers. So we know for sure that a main substance can be seen in every patient, but polysubstance abuse is the classical picture that we are facing every day. In my opinion, the stimulation of the dorsolateral prefrontal cortex made by the RTMS or the TDCS is the possibility that enhancing the control of the cortical structures can in some way control craving in general. And this is true also for every kind of substance. Also, if we are speaking about cocaine or alcohol or gambling, for example. So that specific area of stimulation is a good area. I'm not 100% sure of which is the good parameter to use, but I can say that in my opinion, that is the area to stimulate.
Thank you. We have another question. So would you recommend it as a treatment option in problematic usage of internet? What would be the potential benefits and disadvantages? As far as I know, there are few and isolated findings at the moment referring applications in gaming and gambling addictions, but maybe you know recent. And there are also compliments from this participant who says, very engaging lecture, complimenti Giovanni.
Troppo gentile. What I can say, for sure, the area of internet, the problematic usage of internet is an area where RTMS and TDCS can be very effective. Also because here in this specific addiction, we don't have the substance. So the specific effect on the brain is limited, and on the other hand, the possible efficacy of such a strong technique can be higher. So in my view, we should start to do larger trial, because at the moment we have a very limited number of subjects in the trial available with gaming and the internet disorders.
Thank you. We also have other two questions. One says, how EMDR can reinforce the TMS treatment?
Another very interesting area. We have also some anecdotal reports of the association between breast stimulation techniques and the EMDR. In my opinion, this is something that we could do in the future. But of course, before this, we need to understand how is really working this technique, and then develop possible interactive strategies. But in my opinion, that of the use of EMDR can be a very interesting area.
Thank you. We have another one. Can similar protocols be used for appetite suppression?
We have some data with binge drinking, with binge eating, but it's the same concept that I tried to explain with substance use, because if you're going to control an impulsive stimuli, in some way we can also control the specific binge eating habits. So in this area, I do think that we have ground to do studies, but we have some studies at the moment, which can be interesting.
Thank you very much. Any other questions? I haven't seen anything else written, so okay, they are thanking you. So.
Okay, so thank you so much, Giovanni.
Thank you.
Thank you very much.
And let me introduce the last speaker of this morning session. It's my privilege now to introduce Professor Joseph Zohar, Chain Shiva Medical Center. He's a founder and chairman of the International Council on Ossessive-Compulsive Disorder, founder and first chairman of ICOX, International College of Ossessive-Compulsive Spectrum Disorder, founder and first co-chair of OCNR, past president of ECNP, that is the organization resulting this workshop today, president-elect of SIMP, founder and co-chair of the Israel Center for OCD, is a full professor at Tel Aviv University Chain Shiva Medical Center. And we find his name along the evolution of the treatment for OCD since the beginning. His name is related to the first study with fluvoxamine for the treatment of OCD when it was first purpose and then approved from FDA, and then you find still his name now, and in the future for the next century, I wish. So it's really a pleasure to have today Professor Joseph Zohar. Please, Yossi.
Let's see, because I have seen him connecting before, so.
I wish you have not lost my introduction. We have a few seconds ahead of the time.
Yes. Okay, he's online.
I see his presentation. It is good. And his presentation is going to be about behavioral exposure and TMS FDA study in OCD. That is one of the authors of it. People then bring to the approval of a deep TMS for persistent OCD.
Okay.
Okay, perfect.
אבל אני לא רואה את המצגת.
I already introduced you, but if you want, I can introduce you again.
No, it's okay.
It's okay. Thank you so much. Thank you so much.
You're very welcome.
Thank you.
Professor Joseph Zohar is the director of the National Post-Trauma Center Research Foundation by the Sheba Medical Center, Israel. He is an emeritus professor of psychiatry at the Sackler Foundation of Medicine at Tel Aviv University. Professor Zohar is the past president of the European College of Neuropsychopharmacology, ECNP.
So I'm going to talk about behavioral exposure and TMS. And actually, I'm going to talk about our FDA study. And the presentation is going to have some general background about OCD. I will spend some time talking about where to stimulate, then move to how to stimulate, what is unique about deep TMS. The focus of my talk is going to be when to stimulate, the provocation procedure, and then I'm going to share with you the pilot study result, and then the design and the result of the FDA study, and conclusion, of course. So just a general background. In the past, in DSM-4, OCD was part of anxiety disorder, which include different disorder, and this was basically related, and it includes the PTSD, the GAD, the phobic, the panic, and also OCD. So basically, as we can see in DSM-4, we got this disorder, and OCD was part of anxiety disorder. So this was one family of disorder. Moving from DSM-4 to DSM-5 and adapting the endophenotypical approach, using tools like neuroimaging, the endophenotypical approach is looking at intermediate functioning or circuitry, intermediate between the genetic in environmental part and the express behavioral type. So looking something underneath the phenotype. And looking at this kind of thing, we can look, let's say, at neuroimaging, and looking at neuroimaging, what we can see, we can get an idea about the phenotype, the endophenotype, and looking at this kind of biological marker, if you wish, turn out that the anxiety disorder are not one disorder, but actually should be divided into three families of disorder, which include the anxiety, the stress-related, and OCD, but not only OCD, but it includes also OCD and OCD spectrum. So basically, moving on from DSM-4 to DSM-5, there is OCD is not anymore part of anxiety, and it's not anymore a single disorder, but it is OCD and related disorder. And if we're looking at the related disorder, the spectrum, it's including the BDD, body dysmorphic disorder, hoarding, trichotillomania, and skin picking. So just to give you some idea about the prevalence of OCD, in the past we used to think that OCD is in the neighborhood of 2%. But if we're really looking at other disorder, at the related disorder, including the BDD, the hoarding, the trichotillomania, the skin picking, then the prevalence is actually moving from around 2 to more than 9%. If we include and put together, which is the position of the TSM-5, so we're not talking anymore about one disorder, but talking about OCD and spectrum, then it also implicates regarding the prevalence moving from 2% to 9%. Which brings the point about diagnosis. We don't very often diagnose OCD, or we are not diagnosing OCD as often as we should have. And this is because patients with OCD try to hide their symptoms. And they hide their symptoms because of the ego dystonic nature of the disorder. And how we can improve our diagnosis, there are 5 screening questions that I would argue that is used in the NICE guideline, that were adopted by the NICE guideline in UK. And basically the point is that if you don't ask this specific question each time that you're seeing any patient, you probably will not make diagnosis of OCD, because as I mentioned, OCD patients try to hide their symptoms due to the ego dystonic nature of the symptoms. So the question that we are talking about, the 5 screening questions that we are talking about are: do you check things a lot? Do you wash or clean a lot? Is there any thought that keeps bothering you that you would like to get rid of but cannot? Do your daily activities takes a very long time to finish? And are you concerned about ordinance or symmetry? And the point is that if you don't ask these 5 simple questions, takes half a minute to go through this, you probably will not diagnose OCD as often as we should have. Now, what about the treatment of OCD? So basically, if you look at this slide, you know all you need to know about the first line treatment of OCD, which compose at this point of 2 components. One is the CBT, and more specifically, the exposure with the response prevention. And then the first line treatment are those medication: clomipramine, fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, and escitalopram. And what is unique for all of these medication? All of these medication are serotonergic medication. The CBT, as I mentioned, include first the exposure and then the response prevention. There is no point to do exposure if you don't do the response prevention, and we'll talk about it later while we talk about the TMS study, the FDA TMS study, and we see how it ties together. So as I mentioned, the pharmacological approach to the pharmacological treatment to OCD is very specific, and only one type of medication are working as the first line treatment for OCD and got an indication for OCD. only serotonergic medication. Non-serotonergic medication are not effective, and basically the first-line treatment are serotonergic medication. And also, so we need to remember, while we think about OCD, that we need to be very specific how we are doing the diagnosis, and we need to be very specific how for the treatment of OCD. And we need to remember, as you can see in this slide, that it takes very, very long time to get full effect of the medication. As you can see from this study, at week 8, and yet has not reached the full effect. It usually might take 2, 3 months to get the full effect of medication, and times even longer. What is also unique is that you need to use very, very high dose of medication. And in this regard, serotonergic medication, the SSRI, the new medication, are better, since with the older medication like clomipramine, although it is as effective as serotonergic medication, but with clomipramine, due to the toxic side effect, you cannot go very high, while with the serotonergic medication, citalopram, escitalopram, fluoxetine, fluvoxamine, sertraline, and to some extent with paroxetine, but to lesser extent with paroxetine, you can really go very, very high dose of medication. And at times patients do need very high dose of medication. And if you are using very high dose of medication with this medication, the selective serotonin reuptake inhibitor, you are on fairly safe ground because they are very effective, and the toxic range, and you don't reach toxicity as you usually do, or what you might happen with clomipramine. Okay, so we just covered the very basic of OCD, and now we are moving into the next phase, and the next phase is to talk about where to stimulate. And basically we know that, we treat our brain and we think about the brain as a circuitry, and there are a lot of circuitry, and this is the specific circuitry of regarding the OCD in yellow. And basically we are talking about the corticostriatal thalamic circuitry. Just a minute. So we are talking about the corticostriatal thalamic circuitry, and then the question was, where should we stimulate? You see that there are a lot of possibility in the relevant neural circuitry of OCD where to stimulate, and the idea was to see where it would be the best place to stimulate. Looking at this circuitry, we thought that the PFC is not such a good idea. We also, while we are looking at different possibility where we should focus the TMS, we thought also about the OFC, the lateral OFC. It sounds like a possibility, but by the end of the day, we decided to focus on the ACC and the medial prefrontal cortex. And let me explain to you why the ACC is in increase the activity in resting state measurement. There is increased activity in the ACC in resting state, which is important while we are doing the TMS. There is increase activity following symptom provocation. And as you'll see in a couple of minutes, it is extremely important because we use symptom provocation. And there is very close connectivity between ACC and basal ganglia. And then there is also the issue about the decreased gray matter volume. There is also this close association between ACC and ERN, error-related negativity, which you consider as an important endophenotype in the cognitive sense of OCD. So the ERN is attributed to the ACC activity and most pronounced in the theta band. So basically, so far we talk about that we are the general background of OCD. We saw that it's very prevalent and that there is very specific treatment for OCD, and it is important to diagnose OCD because many times we don't diagnose because of the ego-dystonic nature of OCD. Patients are not coming forward and telling you that they suffer, and you need to ask specific questions. We also focus a little bit about where to stimulate, and we talk about the ACC. And now we need to choose the tool, how to stimulate, and we choose what we call the H-coil or the deep TMS, which allows direct stimulation of deeper neuronal pathway as the ACC. So basically, we believe that deep TMS induce direct and effective field at depths of approximately between 3 to 5 centimeters below the scalp, compared to other standard TMS that might be a little less. And this is specific to the H-coil of this machine. And the idea was that using the H-coil give us the ability to manipulate areas like MCC that are relevant to motivation and reward directly. And the idea is that this is very important in case of OCD. So the H-coil, as I mentioned, is designed to stimulate neuronal pathway in the medial prefrontal cortex or motor cortex, including what we think is important or implicated in OCD, including the ACC, the anterior cingulate cortex. And if we look at the machine, and if we look what is affected, we see that it affected not only the ACC, but it affected other areas. It's not very specific, but it includes the ACC. So now I think the most important part of the presentation is when to stimulate. The provocation procedure. And the idea is the following. Do you want to do the TMS while somebody is thinking about drinking coffee or buying a new car? We don't. Do you want to stimulate while somebody is thinking about his next vacation? We don't. So basically the idea was that we would like to do the stimulation. We'd like to use TMS while the relevant obsessive compulsive circuitry are activated, i.e. during specific stimulation. We'd like that while we are doing the stimulation, the individual would be, the relevant circuitry in the brain will be activated. And for this, in order to achieve this, would like to make sure that we tailor a specific challenge to each of the patients. And then we need to, for checker, we need to do this challenge. For watcher, we need to do challenge that's specific, that related to his washing. For count, for one who is counting, we need to do a specific challenge to tailor the challenge. If you think about this, this is fairly similar to what we are doing in other tests. If we, let's say, if we'd like to get the full picture of the heart condition, we are not doing it while the individual is resting. We are doing it while there is effort test. So we activate the heart, and then we can get better understanding about the pathology, what's going wrong with the heart. The same is with sugar. I mean, we many times are not getting, or is not sensitive enough to measure or to look for diabetes if we don't do the specific activation of the system by doing what we call glucose tolerance test. Think also about the other issue, the issue of light detector. You don't get it unless you ask the specific question. So basically, along the line of this idea, we thought that if we are going to use transmagnetic stimulation, we need to use it in specific situations that are similar to this. It's not just doing it, but doing it under specific challenge stimulation. And the challenge is OCD symptoms will be provoked for each subject in an individual manner in order to activate the relevant brain circuitry. Idea is that if the relevant brain circuitry are not activated, the TMS is going to be less effective or not effective. And then we thought that the provocation consists of photo or script chosen by the subject, which will provoke or induce typical OCD symptoms for the subject, for the patient. And the idea, or what we were trying to achieve, is that the subject will be exposed to it during a period of up to 5 minutes, and the severity, the symptom provocation, must measure between 4 and 7 score on visual analog scale, on VAS, in order to proceed with the TMS. So basically, the idea is that we are not going to start with the procedure unless we are certain that the patient is experiencing obsessive compulsive symptoms while we are starting. Severity is medium, is mild to medium. So it's 4 to 7 on this VAS analog scale. And here you can see, just to give you some idea about this, how it is done, we, let's say we ask the patient, we have the patient plug in an water boiler device in another room, and then he leave the room without turning on or checking the water boiler. or we ask the patient to write down everything that she did this week that may have caused harm, and then stop her after she writes 2 down, and then stop it. So this kind, I mean, and basically the basic concept is to do specific adaptation for each of the symptoms. And as I mentioned, it should be between 3 moderate to major. Not if it's too little, if it's less than 4, we are trying harder and making sure that the patient who is about to undergo the TMS treatment is indeed being challenged. Indeed, the obsessive compulsive symptoms are between moderate and major. Let me share with you how it is done. And this is a patient and is taking the bag of the patient, and he put it in a dirty place. And he asked the patient now what is the level of the distress that she is feeling. And he explained to the patient the different level. And then the patient said that the distress is 4, and he asked the patient why it's 4, what does she think? And he said that she doesn't like that the bag being there because it's dirty. It's considered dirty. And then she move on, say, but it would be even worse if you put it on the floor. This would be even worse. So of course, he put it on the floor, and then, but he put it on a piece of paper, so it's not going to be extreme, but going to be severe enough. And then the patient is telling that she is feeling about 7 on the distress level, and is asking her to stay there. So this is basically the example how we are going to do it. We are creating specific challenge for each patient. And the measure that we use is the Y-box, which is, as you know, the gold standard for rating symptom severity. So we did first pilot study, and in the pilot study, the inclusion were 18 to 65. Back then we used the DSM-4. Score of more than 20 on the Y-box was entry point, and the patient failed at least 1 trial of serotonergic medication. And he was not on active phase of CBT or pharmacological treatment, only on maintenance. So it needs to be stable for certain period of time, for 2 months before starting the study. This was the inclusion in the pilot. The exclusion were axis 1 psychopathology other than OCD, and or a current depressive episode. And again, we use this provocation. We look, these are the measures that we use. These are the sample size, small sample size. You see female and male, and you see the basic things there. This is the cohort starting off with 54, and then 13 were excluded because they did not meet inclusion. Then we randomized, ended up after all this process with 9 in each group. What we found in interim analysis, which was interesting, and this is one of the advantages of doing pilot, is that low frequency, as you can see, the gray was ineffective. It did not separate from placebo. Only the high frequency were effective, so we decided to stop after the interim analysis with the low frequency and continue only with the high frequency. And as you can see, the clinical effect, if we look at the Y box, and if you look on the top figure or CGI score, you see clear difference between active, high frequency, and sham. High frequency in the Y box, there was improvement of 43, while compared to 7% in the sham, and 68 versus 7 in the CGI. So basically, this was encouraging result. And but then, of course, the next step is to try to do a study that enable us to use TMS and to get specific indication for TMS in OCD. And in order to do so, we started with the FDA study. So here is the number of, it was multi-center, and as you can see, there were 9 centers in the States, 1 center in Canada, and 1 center, our center. And basically, this is the procedure for this FDA, OCD, FDA multi-center study, which was a prospective, double-blind, randomized controlled trial. And the idea was to evaluate the safety and efficacy of deep TMS in OCD. One of the subjects diagnosed as suffering from OCD, according to DSM-4-TR, were recruited for the study. Inclusion were Y-box score of more than 20, and subject, as in the pilot study, were maintained on SRI medication, same dose of SRI medication for therapeutic dose for at least 2 months prior to study entry, and they were on the same dose and the same medication for the duration of the study. And there were also, the same was true for CBT, behavioral intervention, they were maintained. There was not an active phase of CBT, but on maintenance. The treatment, there were 5 weeks of daily treatment of TMS, which the H coil, followed by 4 treatment in week 6. So there were total of 29 treatment sessions and about 2,000 magnetic stimulation per session. Prior to initiation of each treatment, as I mentioned, OCD symptoms were provoked for each patient in an individual measure to activate the relevant brain circuitry. So this is very unique in this regard. This is the first time that there is combination of specific behavioral challenge are being carried out as part of using physical stimulation. Patient and investigator were blind, of course, and the randomization ratio was 1:1. We use as primary endpoint the Y-box score from baseline to the 6 weeks post-randomization visit between the two treatment groups. So active versus placebo versus sham treatment, comparing at the end of the treatment to the beginning. And then we have a secondary endpoint, which include comparison of the change from the baseline to the 6-week visit in regarding Sheehan disability, looking also at clinical global impression and improvement. So it's not only the Y-box, but also the Sheehan, the global impression, the CGI, and global improvement. We also look at secondary endpoint at response rate comparison at the week 6, and we look at reduction of 30% as responder. We also look, and you'll see it later, as or define partial responder as individual that there was reduction of 20% in the Y-box score between baseline, between the treatment groups. So 30% as responder and 20 as partial. And then we also look at remission rate comparison at week 6, where the remission is defined as Y-box score as a single digit, less than 10, between the treatment groups. So 99 patients were randomized, 94 met inclusion-exclusion, and as I mentioned, 11 sites, worldwide, 9 in the States, and 83 completed the study. The treatment was focused on the ACC and medial prefrontal cortex, 20 Hertz, 2-second train duration, 20-second inter-train interval. There was 100% of leg motor threshold, 50 train in each session, 17 minutes, 2,000 stimuli per session, and 29 treatment sessions for the treatment. If we look at the different centers, and you see how many patients were recruited for patient, and as I mentioned, very important part of this study and very important part of this talk is the provocation procedure that I mentioned earlier and demonstrated earlier, basically making sure that the patient, while going through the study, is being provoked. Making sure that the patient, while going and doing the TMS, there is activation of the specific relevant circuitry of the circuitry relevant to OCD. And we talk about this, how we can do it, and what level of distress, what level of engagement in the obsessive compulsive symptoms we like to get, and the level is between 4 and 7 on VAS. So this is the flow. Phase 1 was screening, and then there was phase 2, sham versus active, and then which finished at week 6, and then another 4 weeks of follow-up to see long-term or lasting effect of the stimulation. Here you see the age and the gender and the Y box and all the demographic and relevant data. And here are the results, some of the results. You can see that there was significant difference between the sham and the active. The active is yellow, and we got this difference starting from week 3, moving on to week 6, and it stays there also for a week 10, i.e. 4 weeks after we stop the treatment. So the treatment itself went from up to week 6. So now, if we look at response rate, 30% reduction in the Y box, and partial 25% rate at 6 weeks, you can see difference between the real in blue and sham in gray, and you see the response rate were clearly different between the active and the sham. If we look at the effect size, what we are getting with the medication, that got an indication for OCD, what we are getting with medication that are considered as the gold standard treatment for OCD, what we see is that what we get, the difference between active, fluoxetine, Prozac, and sham is 3 points on the Y box. The difference with Zoloft, with sertraline, is 2.4. With paroxetine is 3.3. Fluvoxamine is 3.8. And then you see on the green, on the very right column, the difference that we get with the TMS, and you see that it is equivalent. It's 3.1, the difference between the active and the sham. So basically, the effect size, the mean change in total Y box at SRIs, at serotonergic studies, and with the TMS is basically the same. Of course, we do need to remember, this is important, that this patient, the patient that were treated with the TMS, were patients that either failed on SRI treatment or the response was not good enough. Otherwise, they would not have come to the study. So basically, this suggests to us that might be that the mechanism in which TMS work for OCD is somewhat different from the mechanism that serotonergic medication are working, because we are getting additional significant different in patients who are treating with TMS. On the left side of the screen, with the blue, we see patients who are not getting serotonergic medication. We're naive. On the right side, on this study, on the fluvoxamine study, we include only patients that were on serotonergic medication but didn't responded well enough to serotonergic medication, which make the result even more impressive in this sense. If we look at the effect size as a N and T, we see it's for the week 6 is 3.7, and at week 10 is remaining 3.6. Okay, the conclusion. The conclusion is basically that moving from DSM-4 to DSM-5, OCD is not anymore part of anxiety disorder, and it's not anymore one disorder, but it includes OCD and OCD spectrum. If we look at the OCD spectrum, included OCD, OCD and BDD, OCD and hoarding, OCD and trichotillomania and air pulling and skin picking, and think about the prevalence, we realize that including the OCD and the OCD spectrum, OCD related, we are moving from prevalence of about 2% to 9%. And OCD is disabling and chronic, and this is why it's so important to treat OCD. And so far, the treatment for OCD, the specific treatment, include CBT, the in vivo exposure coupled with response, prevention ERP, and specific pharmacological approach. Only serotonergic medication turn out to be effective. We talked that in this particular study, we focus on the ACC, cingulate, and we use the H coil that can reach the anterior cingulate. And we say that in this particular study, and I think if we are considering doing TMS, we need to realize that at least the FDA study suggests that we should do this only under stimulation. And we look at the pilot result. Low frequency was ineffective, only high frequency was effective. And if we look at the FDA study, we see the significant effect of active versus placebo using TMS in OCD patients who did not respond well enough to serotonergic and or behavioral approach. Using TMS, we got extra benefit for this patient, and the effect size that was reached with TMS was similar to what we get with serotonergic medication. So the conclusion is that high frequency deep TMS over the MFC and ACC is safe, and it is effective intervention for alleviation of OCD symptoms. And I think we can include this as another possibility while we are looking and treating OCD patients. So we got now the psychological approach, we got the pharmacological approach. We can think now, based on this FDA study, adding another arm, the TMS arm. Thank you very much.
Thank you, Joseph.
Thank you.
Thank you for all these interesting details in this new procedure for the treatment of OCD. Let me ask you something about, do you find any difficulty in different subtype of OCD to figure the precise, the individual exposure? I mean, are any different, you know, if you have to prepare this exposure for a patient that is a checker compared to another instead that is a doubter or other kind of fears?
Yeah, it is, you know, it's a good point, and I think really the most challenging part of doing it is really by that we need to tailor the specific challenge. And this is something very important. And it's not always easy to do this specific, this specific challenge and to provoke the patient. And you do need to know the patient well in advance and to prepare it. And the point that I'm making, I hope it was clear, that we don't know what would have been the effect of treating the patient with TMS without this provocation. And I think this is something that we can study. Our impression is that it is important to have this provocation, and this is part of the study at this point.
Thank you. A question from a participant who asks, can the outcome be a synergistic effect of both SSRI and TMS? Participants were recruited after 2 months of initiation treatment with SSRI. Many patients respond to SSRI even after 3 months.
No, the participants were not recruited after initiation of the treatment. The participants were at least 2 months on same dose of medication. It was not because it was not, I mean, we didn't, most of the patients were on the medication for more than a year. The inclusion criteria were that the patient were on the same dose, on maintenance, for at least two months. But this was not after initiation of the treatment. This was after the patient were stable for at least 2 months on the same dose of medication.
Okay, thank you. I have another question. So, does the effect of treatment last beyond 10 weeks?
This is excellent point, and we don't know. This is something that we need to study. I mean, at this point of time, we do know, and I show it that it is effective. How long the effect lasts, we actually don't know. And this needs to be studied. We are hoping to study it more carefully, but we don't know. We only know 10 weeks. Our impression is that it's help you to move to another level. And once you are reaching this, it's easier to continue on and to push on the behavior and on the exposure and going back to work and going back to full functioning, but we don't know.
Thank you. We have another question. Any comments on approaching the pre-SMA versus ACC in OCD patients?
Say it again.
Any comments on approaching the pre-SMA versus ACC in OCD patients?
I see. We thought that, and I tried to some extent to explain the rationale why we focus on ACC, and basically the data that we got is related to ACC. And we don't know whether, again, it would be effective as we use or focus on other area of the brain. We don't know. And as I mentioned, we also don't know whether or not the using TMS without the provocation would be as effective as using it with the provocation. The reason that we choose to do it is provocation was to maximize the chance of getting a signal. The idea was that if we'll do a study and will not get a signal, then it's unlikely that it would be possible to do other study. So the idea was to try to maximize the chance, and we choose a ACC, thinking that this is the best location, and using the provocation, thinking that this is the best approach.
Thank you. We have a comment which says, for most of our clients, we give one session of RTMS every month for maintenance. So do you believe this is a good strategy? Do you have different...
I think it's an excellent idea. You just need to, I mean, I would, it would be very interesting to see what is the effect. And, the best approach is, of course, to try to do proper study. Proper study means that you are doing it, and then, for some of the patients, you don't do it. Some of the patients, you do it, and then you do it in every 2 weeks or every month. But I think at least at this point of time, would be interesting to see for this particular patient what would have happened as they stop it for 1 month, if there will be a relapse. But I think it's very important study.
Okay, thank you. So if anyone has some question, please write it now. Otherwise, I think, okay, so no other question. So we thank you a lot. Yeah, thank you, Joseph, for this new interpretation of the results of your research. Very pleased to learn a lot from your presentation. Thank you. And so this is the last of the morning, so we have now a little break. We'll regain the meeting for the practical aspect of TMS2 according to the schedule. So you can have a sandwich or something, depending from where you are now, and see you at 2 o'clock. Thank you, Joseph. Thank you, everybody.
Take care. Good luck.
Bye. Thank you.
Dr. Anna Maras holds a PhD in neurosciences and is a research fellow at the University of Florence for the clinical coordination of the R21 project, modulating inhibitory control networks in gambling disorder with theta burst stimulation. Led by Professor Nikos Makros, Professors Joan Campradon, and led by Professor Stefano Pallanti.
We are going to talk about neuronavigation procedures, as Professor Pallanti said. This is important since we usually choose the target for RTMS with methods which are named as conventional targeting methods, which are basically the 1020 EEG system, or we use external landmarks to identify the target. So as you see in the picture, this is the 1020 EEG system, which is a quite common system used in electroencephalography, which is a map in which you can calculate the distances between different points, each one with its name, an alphabet letter and a number. We have numbers for the left and for the right side. And this is the most common used method of targeting. Otherwise, you can use the 5 centimeter rule, which is especially used for the DLPFC, so the dorsolateral prefrontal cortex. This is quite an easy method, but not very precise, because it is based basically on the identification of the hand motor hotspot. So once you have identified the hand motor hotspot, and you see the movement of the abductor pollicis brevis, which is the muscle you see twitching, you move anterior by 5 centimeters, and then you locate the dorsolateral prefrontal cortex. So here you see the hand motor hotspot, which is located on the median line of the head, right or left to the vertex of the head, which is CZ in the 1020 EEG system. So you move forward to the left or to the right, and you identify the correct hotspot when you see the movement of the hand, or you have the maps you can see by the potential. But what's wrong with this procedure? In this slide, you see the difference when you find the target with the neuronavigation procedure and when you find the target with the 5 centimeter rules. So when you find the target of the hand motor hotspot, which is the green here, you see there is no great difference between the conventional standard procedure and the neuronavigated procedure, because you have an indicator when you find the right spot, because you see the movement, so it's easier. But when you move to find other targets outside the motor cortex, you encounter more problems, because as you see here in the red points, the square point is the DLPFC found with the standard procedure, which is here. And the circle is the DLPFC found with the neuronavigation. And you can see there is a lot of difference. In fact, when you use a navigated procedure, you are quite sure to target the DLPFC. Otherwise, when you use the 5 centimeter rules, many authors found that you basically go over the premotor cortex instead of the DLPFC. So you have a great error. And why do we need to use neuronavigation? Because we have a lot of inter-individual differences. As you can see in this kind of photo, the same head may have a difference in internal anatomy, and also you have a difference in size and in morphology of the brain cortex. So the optimal target becomes very challenging. Basically, neuronavigation refers to a set of techniques that are used to navigate the scalp. So you use to locate different brain areas, especially cortex areas, and so to identify the targets for RTMS. Neuronavigation as stereotaxic neuronavigation is used also in neurosurgery. But for our interest, what is important is the scalp, so the external part. Neuronavigation allows a 3D mapping of the skull surface, and it can be performed with or without MRI imaging. So you have a real image if you have an MRI for the subject, or you can have an estimate. So you have an estimated reconstruction of the head of the subject. One of the most important purposes of neuronavigation is that you have coil positioning reproducibility. So you can be sure to position the coil every time in the exact position. A neuronavigation system is usually composed by different tools that you will see in a while. It is composed by a position sensor, which is an infrared camera, which is usually mounted as high as it can have a vision over the head subject and of the operator moving. you have wireless markers. You have 3 wireless markers. You have one placed on the subject head, so it gives the spatial coordinates of the head of the subject. You have one placed over the coil of the machine, which ensures the reproducibility of coil positioning. And you have a stylus that you have on your hand to map on the head of the subject, which is this one in the slide. And also you would need a laptop or a computer, a workstation with the software for acquisition that will guide you during all the procedure. So let's see here very quickly when you have a subject MRI, because after we will see the estimated procedure. For practical reasons, it will be easier without the subject MRI, and also for privacy reasons. So when you have the MRI, which is usually on a CD, so you have DICOM images or NIFTY images, you can upload them into the software, and here you see that you have a reconstruction of a 3D model of the head of the subject. So you see also the external part, the scalp, and you also have a reconstruction 3D of his face. After uploading the MRI of the subject, you will be asked also to check more reference points, because the spatial coordinates on which the neuronavigation is based are mainly 3 or 4 points of the head of the subject, which is the nasion, the inion, so it's the left, the posterior part, and then you have the 2 tragus, so the left and the right tragus, which is preauricular 1 and preauricular 2. So these 3 reference points are anyway used by the software. After checking for these reference points, if you have the MRI, again, the software will extract a brain model for the subject. And then for refining with a procedure which is called best fit, you will have to take other 9 points with your stylus over the head of the subject. Then we'll see how we will take all the points of the head of the subject, because we will have no MRI. So this procedure is usually faster if you have the MRI. And then here is the final window for the software when you navigate. This is the real navigation procedure, because you have taken all the points of reference on the head of the subject, and then you will have the coil to be aligned to those points. So on your left side, you will see this is called the navigation radar. So you will have some points in green that will become red if you go the wrong way. So if you move on the wrong way, it will go red. And when all the cursors are aligned, you are sure that you are on the right position. So this is the procedure when you have the MRI. The first part we will see in a while, it's very similar, because the only difference is that you have to make an estimate, because you don't have any image. So you will have to take all the reference points, and you would have no clue of the inside real brain of the subject. So, but anyway, the estimated procedure is the most used when you don't have an MRI of the subject, which is usually not quite easy to have here, at least here in Italy, because it's quite expensive, and it's not really cost effective when you ask a subject to have an MRI only for neuronavigation. So it's used when you already have an MRI that fits the software. Otherwise, you can go with the estimated procedure. So the estimated procedure will eventually grant enough procedure if performed correctly, and we will see how to do it. And as I said, it is cost effective when the MRI is not available. So it's definitely useful. And now we will see how to proceed on an average. We have just set up the wireless tracker, so it is fixed on the head of the subject by means of an elastic label. This is the trackable wireless tracker from this infrared, and you will also have the stylus in your head. So this is the software where you can see the window. Here is the infrared camera, and here you see the two trackers, which are now yellow because the tracker can see the reference points. Now you see, okay, you can adjust your camera. So, okay. Now you can see the green button, so okay, the head is visible, and now also the stylus is in the field of the camera. Okay. As you see, it asks me to take 4 points: the nasion, the ilion, the left preauricular, and the right preauricular. And I also have here this button to be to do all by myself, so I can take the registration and the reference point by myself without any help. Okay, so let's start. We'll take before the first point, the nasion. So this is the place. Okay, now we are sure and we can click. Okay, the ilion. So when you touch the head of the subject, you see here that you have a little space here. Okay. Then it has the left preauricular, so the space in the tragus, just above the tragus, here. And on the right, the same thing, so here. Okay. Then you will see it has given me some coordinates in the space, okay? So let's check if we are correct. Okay. So now you see that we have the radar. So it's now guiding me on how to go, where to go with my stylus to take all those points that are missing, okay? So I have moved the head, so now the points are all mistaken. It is better if I start over, because the head must be in the same place for all the procedure. So now you have seen how I've taken the points, but for me it's better to be still. Okay, this should be better. Yes, definitely better. Okay, so now you see that on the top screen, the navigation system is guiding me. This is the movement of my stylus. And you see the red point is moving. Now, quite difficult to understand, because it is guiding me where I have to go. So the red point is telling me that I need to go on my left and just posteriorly. So as you see, I'm moving. I have to find the first point that is the vertex of the head, which is CZ. So it will be a place around here. And now it is telling me that I'm to right and that I need to go left. Okay, so I'm moving. This is usually done with the head of the subject, which is still. Okay, so I'm guiding my hands, so it's easier. Okay, now it's telling me to go. Okay, okay. When you have took the right point, you can click, and now it is registered. So the next point. So now it tells me FZ, which is approximately the pre-SMA. So we can move forward. Okay. and quite left. Okay, done, and click. Now I'm moving posteriorly, so it is PZ, okay? Because the system is useful in this way because it teaches you to find the sites on sagittal lines. So the first three, then on the right, then all the points on the left. So let's follow his instruction. Okay. Okay, then we move to AF4. So it's the right side. It's the prefrontal side on the right. Yeah. Okay. Okay, F4. So we are doing all the right side. Okay. No. Okay. Now even posterior to the motor cortex because C3 and C4 on the 1020 EEG are usually the primary motor cortices. So it will be around here. Okay. P4, so even posterior. So one cue to be precise is to watch only the navigator. I'm usually not watching the map on the left because it distracts me. Okay. So now even on your right, more on the right. So even posterior. Okay. And P6. Oops. Here we have it. Okay. So now we move to the left side. This might be somewhat tricky because you have the pointer on the head of the subject. So in some points it would be trickier. So now we have the motor cortex again. All right. Okay. I have the hand. All right. Now the occipital site. Very near. Okay. Okay. This is the trick here because we have the tracker on. Okay. 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 And P5, which is the last one. Now you will see after this one, okay, the reconstruction. So you go next, and you see that we have a model. So we have a 3D model of the head as we have reconstructed. Next, you will have a better model. Okay, as you can see, this model is an estimated model. So you will have an estimated inside of the head, of course, but what you have reconstructed is the surface. So it's this part here. Okay, you will give a name, which is average Joe. You will give him an age, 35. than 70 kilos, for example. Okay, and this is the thing that you wanted to estimate. You have your reconstruction of the head, complete until the ear points, because as I told you, we have taken the reference point, which are the nasion, the ilion, and the preauricular ones. So you don't need all the lower part. And this is the inside reconstruction, okay, where you can also choose to have a different threshold, but we usually left it quite low. Okay, so that's better, okay. And then you also have another estimate, which is the brain. Of course, this will be an estimate, and you can see in the different orientation. Okay. Once you have finished this procedure, the system saves these coordinates. So it saves the coordinates for the name of the subject, and you will have its head. So you can see also where is the tracker, and this is the position in the space. Here you can go to the navigation procedure, and you can import a coil, and it will give you the information on how to position the coil on the right point, and every time in the same position. As you can see here, you have two other navigators, and these are for the coils. You would have to import the calibration of one or two coils, and each time it will give you the exact position of the coils on the head of the subject. So this is the complete procedure and the results. Okay, so this is the first part done.
Well done.
Thank you. Ok, allora torniamo all'altra. Ok, vi attacco il mio. Okay, so I hope you can hear me from here, maybe. And if you have some questions before the next presentation, you can also ask me now, because we will then follow with the part regarding the TMS protocol. You will see the machine, and you will see the setting of the protocol. So if you have some questions regarding neuro navigation, you can ask me now. Otherwise, I will go ahead. Okay, let's go ahead. Let me share my screen with the correct presentation. Yes, it is possible to have the recording. We are recording now. You would have the recording in a few days once we have managed to set everything up, of course. Okay. So let me share my screen. Okay. Okay, you would see my screen now, and okay. So we have seen some neuro navigation procedures, and now we see the applications. So we have talked a lot about RTMS in OCD. We have seen contribution from Professor Pallanti, from all the other speakers. So now we have just a little sum of where we are now. Maybe this slide is better this way if you can see it. We have a meta-analysis, a recent meta-analysis of the effectiveness of the different targets in OCD. You see in the table that we have lots of studies on the DLPFC, most studies on the DLPFC, because it has been the first target that has been investigated, mostly the left, but also the right DLPFC. And we have little studies on the orbitofrontal cortex, and then we will see why, and a low number, anyway, of studies on the supplementary motor area. You see in the table on the right the number of studies, and otherwise on the left you see the results of these studies, where you see just at the first sight that most investigations favors active RTMS on sham TMS, and this is especially true for what concerns the supplementary motor area, because it seems that it yields the greatest reductions in Y-box scores. And on the whole, it seems that low-frequency protocols are more effective than high-frequency RTMS. This is not very consistent with the last evidence-based evidences, because in 2020 the last evidence-based guidelines have underlined that we have only a possible efficacy of RTMS in OCD, so a level C of efficacy, and only for low-frequency protocols over the right dorsolateral prefrontal cortex. This might be motivated by the high number of studies towards this target. Otherwise, as I said before, we have lots less targets, studies with the targets on OFC and pre-SMA. Also, a couple of years ago, FDA cleared the BrainsWay device for deep TMS for OCD. So we had an approval, and these have arisen from the work of Lior Karmi and Drs. Zohar and Zangen that we heard this morning and yesterday. So their protocol of simulation has been approved, and it is the high-frequency deep TMS. So we will see with a different coil from the repetitive TMS over the medial prefrontal cortex and anterior cingulate cortex, so MPFC and ACC. Apart from this deep TMS protocol that has been approved, we have three main targets of neuromodulation with RTMS in OCD. As we saw before, we have the dorsolateral prefrontal cortex, which is related to cognitive control. We have the orbitofrontal cortex, which is related to the top-down regulation, and it is a core component of the circuitry of OCD, and the supplementary motor area and its anterior part, which is a portion called pre-SMA, which is related to motor inhibition and to the concept of response inhibition. Very briefly and also very simplistically, we see why we choose these targets and which is the function that is related to each target. So we have the DLPFC with executive functions and cognitive control and decision making. We have the OFC with an emotional value because it is related to the anticipation of a negative affective value for future events. So here you understand its involvement in OCD. And you have the SMA and the pre-SMA as related to the response inhibition. And also you see very briefly their dysfunction in OCD, where you have mainly an hyperactivity of both the OFC and the pre-SMA during specific tasks. So you can correlate the activity and the metabolism of these areas while the subject is performing a specific task. what we have as a brief summary of the evidence of the use of RTMS protocols in OCD is summarized in this table. First, you have high-frequency protocols over the left dorsolateral prefrontal cortex. As I said before, we have lots of studies on the DLPFC. We have, as a result, an improvement of OCD symptoms, but we have a general result which concluded that they are not enough superior to sham stimulation. And maybe this is due from the lower number of stimuli and a lower intensity, because these were the first studies, and as we know, for every disorder targeted with TMS, the first studies usually employ a low number of sessions, a low number of pulses, and a low intensity. While we now know that the better outcome is correlated with a high number of pulses, a higher number of sessions, so the dosage is quite fundamental. Otherwise, low frequency protocols over the orbitofrontal cortex. Here we have not many studies, only two main studies in the period between 2009-2016, and we only see temporary effects because we have good results, but not very long-term as consistency. Also, another problem related to targeting the orbitofrontal cortex, it is that it's an area which is difficult to reach with the usual figure-of-8 coils or butterfly coils, because it's deeper and it's more difficult to reach. Then on to studies over the pre-SMA. We have low frequency stimulation over the pre-SMA because its hyperactivity is considered as a candidate endophenotype of OCD. So its hyperactivity is seen both on OCD patients and first-degree relatives. So it is considered as an important finding and quite consistent with the pathology. And the low-frequency RTMS over the pre-SMA has the most encouraging results because the effects are lasting up to 14 weeks. And this may be due to a stronger connectivity of the SMA to the striatal regions. Now, of course, all the exact mechanisms of efficacy of RTMS are not fully elucidated up to now, but we can only make some hypotheses. Otherwise, with the studies on the pre-SMA, we also have some contrasting results because it is not quite effective in highly refractory patients, and also we have a low number of studies. And then on to the last of the targets, which is the ACC, which has been targeted with deep TMS. So as you saw before, it is the studies, these are the studies that came to the approval by the FDA. So we have a different coil, which is called H coil. And the result we see with this kind of stimulation are the result of the sum of cortical and subcortical effects, since the penetration of the magnetic pulse is deeper with H coils than for standard coils. So now we can see the parameters for stimulation for each target. Because as we have seen, we have both low and high frequency stimulation, and it depends from the area that you want to target. It depends from the rationale. So if you have a hyperactivity or hypoactivity of the area, and then you have to choose which frequency and which intensity, with how many pulses, and the total number of pulses of the session. You can see as a general rules that you have already heard before from other speakers, that generally low frequencies, which is conventionally considered as 1 Hz, are usually inhibitory, while high frequencies, which is 5 and above, are usually excitatory. This is a general rule, but it is not always true, because you have also to consider the resting state as features of the system that you stimulate, but we can use this as a rule. So on the DLPFC, so on the dorsolateral prefrontal cortex, you have 2 main protocols. You have a low frequency on the right or a high frequency on the left. You see that these are generally all the parameters you need for to set up a protocol of stimulation. So you would need a frequency which says how many pulses in a second you have from the machine. So in a low frequency you have 1 pulse per second, while on a high frequency you have very near pulses up to 10, 20, 30 or 50, like in the theta burst. Then you have the intensity. So the intensity refers to the resting motor threshold of the subject. So you have to identify the motor threshold of the subject, and you do this by the hand motor hotspot. So you deliver a single pulse on the hand motor hotspot. You see the movement of the hand, or you see the map if you have the electromyography, and then you can choose to have a stimulation over threshold, so supra threshold, or sub threshold, so lower. Usually low frequency protocols are over threshold, so you have 110% to 130%. So, but in most of the cases is 110%. While most of, we will see later, theta burst protocols are under threshold. Then you will have to choose how many pulses you will deliver per train. So you have a consecutive train of pulses, and in the low frequency protocols, usually you have 10 consecutive pulses and then a pause. This pause is called ITI, so intertrain interval, and it is regulated by safety guidelines. You can find safety guidelines by Rossi and colleagues from 2009, and you will also have the first guidelines from Wasserman, which are from 1998. And this regulates the minimum period between 2 trains of pulses, which is safe, not to have any risks of seizures or other side effects. So you have 10 consecutive pulses in a train, an interval of 3 seconds, and then again another train. Then you have to specify how many trains. And you have 120 to 160 trains for a usual low frequency stimulation protocol, which consists in 1,200 to 1,600 pulses of a total. And you can see for the high frequency, these are the same parameters, but you have a difference of a greater intertrain interval. So you have a longer pause between pulses of between train of pulses, because the high frequency is quite more related to the risk of seizures than low frequency. It is anyway a very low probability but it's more probable with high frequency stimulation than with a low frequency stimulation. The same parameters are for a low frequency stimulation of the orbitofrontal target. You see here that the only difference is the intensity. So we have in some studies an intensity on the lower levels, so not even at a threshold level. And finally, the parameters for stimulation over the SMA. In this case, we have an above threshold intensity. This is one of the hypotheses that we can make for this target, that a suprathreshold stimulation would be more effective. A brief mention to deep TMS. So here you can see the difference from a standard procedure and especially a standard coil, because you see that the coil here is an helmet, so it's wearable by the subject, and for this reason it goes beyond and penetrates deeper and can reach more deeper areas of the brain. In this case, as we saw for the approval from FDA, we are speaking of a high frequency protocol, which is 20 Hertz, and its intensity is 100%, because usually you try to keep it low, the intensity for high frequency protocol, usually for safety reasons. And also you see that it has a long intertrain interval and a high number of pulses, which is consistent with the late reports, which correlates the number of pulses with a better outcome. Then we can see the theta burst stimulation. In this slide, you see a very brief summary of the protocols of rTMS. You see the rules for inhibitory and excitatory stimulation. So in repetitive TMS, you see low frequency is usually inhibitory, and high frequency, which is usually excitatory. For theta burst stimulation, which is now you will see a TMS protocols that uses high frequency triplets of TMS, which are called bursts. This is why the name, that are given every 200 milliseconds. So you have three very near stimuli in triplets, which are repeated at a frequency of 5 Hertz. This can be in two ways. So it can be a continuous theta burst stimulation. So when you have no free interval, you have an uninterrupted train of pulses for 40 seconds of triplets of 50 Hertz. This kind of stimulation, which is called CTBS for continuous, which is this one, and this is the continuous you see in the diagram, which is continuous, mimics the effects of a low frequency rTMS. So it has the same effects of inhibition. Whereas the intermittent form, which is patterned, because you have trains of 2 seconds consecutive, and then you have a intertrain interval of 8 seconds. So you have triplets patterned with 3 intervals, and the total duration so is 3 minutes. This one mimics the effects of a high frequency. The idea to choose a theta burst stimulation is mainly an idea of efficiency, because it has a very, very shorter duration than standard protocols, because it is 1.5 minutes to 3 minutes, as opposed to 15 minutes or 30 minutes for the pre-SMA, and it also leads to stronger neuroplastic responses and longer lasting behavioral effects. So this in sum is the these are the parameters for the theta burst protocols. You see that what is differential is the waveform of the stimuli, because in the machine you have to select the stimulation type in burst. So it has the groups of triplets of 50 Hz. And you see this is the 50 Hz. So these are the pulses frequency in burst, so in a triplet. And this is the interval on which you have each burst. So every 200 milliseconds, which is 5 Hz. As I told you before, the intensity for theta burst protocols is usually lower. You have 80% of motor threshold for safety reasons. And this is what we said before. So the continuous protocol is uninterrupted. So you have a shorter intertrain interval, quite near to 0. And you have only one train of 40 seconds for a total of 600 pulses. So you have, if you see the difference with another protocol of RTMS, remember 600 pulses in 40 seconds. Here you have 1,600 stimuli in a SMA protocol, which is 32 minutes. So you can see the difference in time. And this is the same for ITBS, which, since it is intermittent and it has pause between one train and another, it's a little longer because it is 3 minutes. So before going to the practical part where you will see the machine, this is an idea of the TMS equipment. I don't know how many of you are familiar with the equipment. This is only one of the machines because there are many manufacturers. This is from MagVenture, but we have MagSteam, we have BrainsWave for deep TMS. So this is an example. You have an equipment composed by the general stimulator, which is this one. This is the generator with any adjunctive modules for theta burst, for example. We have the refrigerator unit, a transformer, and this is the core point because this is the coil, and this is the part that will be on the head of the subject. And there are many kinds of coils. You will see here the one that we have now equipped on our machine, which is the butterfly coil, which is refrigerated, so you don't have any problems with overheating, which was a major problem like 5 to 10 years ago when you had no refrigerator and the heating was real, because after 5 to 10 minutes you have the machine went stopping by itself because it was overheated, and you had only the possibility to deliver 200 or 300 pulses to the subject, and then you have to get a pause. And now with the refrigerated coils you do not have this problem anymore. Briefly, this is the way to get the motor threshold for the subject. So this is the window of the software of the MagVenture. You see here, this is in Italian, sorry. You have the setting for the protocol you choose, and for the motor threshold it is called treat MT for motor threshold. This kind of protocol allows you to give one single pulse, and so you can see if you see the muscle twitch or not, or if you can see the map or not. So you choose this protocol to deliver a single pulse when you want, directly clicking on the coil. And you usually start with an amplitude of 40. This is a conventional value. It can be 40 on MagVenture machines. It can be 60 on MagSteam machines. So take it as it is for this kind of machine. And now you will see better than after with the machine. You will have this kind of windows that allows you to set up the protocol. You have, maybe, let's see if you can see better this way. You have a home menu where you choose your setting and you choose your protocol. They are usually named with letters of the alphabet. You can choose how to name them, so you know that, for example, A is low frequency, B is high frequency, C is low frequency with 1000 and 1600 stimuli, so you know, and you can choose that. Then you click on select, so you recall your protocol, and then you click on timing to activate your protocol. Here is an important part, in my opinion, of the software, because it lets you see the parameters. So in case you have made any mistake in choosing the wrong protocol, you see if it's right or wrong, because you have a schematic representation of the protocol where you see the single pulses and the intertrain interval, and you also see them written down. Once you are sure that you have chosen the right protocol, you can click on go, and it starts. It starts and it lets you see both the parameters and the advance of the protocol. So you see the percentage and the minutes left and done. Okay. So we will see the demonstration. So we will close. Okay, so here you see the machine. This is the machine you saw in the slides before. This is exactly the same. It's the MagVenture, Mag Pro. This is able also to deliver theta burst because it has adjunctive model. It has an equipped butterfly coil, which is refrigerated by a liquid. So this is the refrigerated. And here you see that this is the home window. So you have to choose at first your protocol. You see here we have saved protocols with a conventional letter of the alphabet. I know that A stands for low frequency with 800 stimuli, that B is high frequency 10 Hertz with 1600 stimuli. Then you have treat, MT, which is for the motor threshold, and then you go on with the other letters. Let's see the motor threshold protocol. So you have treat MT, and you recall. This is the button in Italian for recall. Okay. Then timing, temporizza in Italian. Okay, so you see here that you have a sequence and that you have only one pulse per train. So on this part of the coil, you have a little button. Now you will see it as I move the coil. And you are able to click on that button and deliver a single pulse. Then you have to activate the coil. So let's move with an amplitude of 40, which is conventional. And so you can also hear the click. Okay. And these are the single pulse. We have a little button here. And these are the single pulse. So I can move in the meanwhile the coil. So let's pretend we have a subject around here. And I can move the coil any way I want. And also, maybe for the motor threshold is better because you can detach it. And this is the easiest way to move. So let's pretend we have a subject here. So you can move anywhere you want. And anytime you move, you can deliver a pulse. Okay. Then for stimulation, it is better to secure the coil here and to move the flexible arm. So it's easier and safer. So then you can deactivate the coil again, and you can go to the home window. Again, you will have to choose your protocol. Now let's see the difference. You can hear also the click from a low frequency protocol to a high frequency or a theta bars protocol. So I told you A for us, it's low frequency with 800 stimuli. And here you see also the parameters. So you see 1 pulse per second, so it's 1 hertz. You see pulses per train, which are 10. You see number of trains, 80, so it's 800 stimuli for a total session, and the ITI, so the inter-train interval of 3 seconds. Okay, let's see. So you have choose this one, you have recalled it. So now you activate the coil. Let's pretend we have the subject correctly positioned. You have his value for motor threshold. Let's say it's 36. And now you can only launch the protocol. And now you can hear, you have 1 single click, 10 seconds. Okay, and then the pause. 3 seconds and starts again. So it's completely saved by the system and it's automatic. Once you have saved in this machine, once you have saved the protocol with the correct parameters, it is saved, and you only have to position the coil and launch the protocol. Then during simulation, you can follow the stimulation on this bar. So you can follow the duration, and below you can follow the number of pulses. Okay, you can pause and go again, or you can interrupt, so it stops all the protocol. Okay, you go back again to the home window, you deactivate the coil, and let's see a high frequency protocol. B for us it's 10 hertz. So, okay, so you see again here 10 pulses per second, which is 10 hertz, and 50 pulses per train, so it's 5 seconds. And then you have 32 trains and an inter-train interval of 25 seconds, as we said before, for safety reasons. Let's activate the coil. And again, 36, and go. So this is a different pattern, as you see. Now we will have a longer duration of the inter-train interval. So we are in this part here. We have done the stimuli, and we are here now. And also you will hear that before starting again the train, you have a sound that also advises the subject when the next train is going to start again. Here it is. Okay. Okay. Last one, we can hear and see a theta bars protocol. It is the continuous, this one, the N for us conventionally is the continuous theta bars. And also you see here that you have the description as the waveform in biphasic burst. Okay, so the parameters, again, as I told you before. So now we activate the coil. Let's give it a little lower because it would be 80%, so definitely lower. And now, if you can hear, you hear triplets of bars, of pulses. This is continuous, as you can hear, never stops, 39 seconds continuous. And this would have an inhibitory effect. So, in the sum, these are 600 pulses in these 39 seconds. Okay, we can interrupt, and at last, the difference with a patterned theta burst, the intermittent one. Okay. Stop. And this is the pattern, the pause. And it starts again with a sound. Okay? So you see, this is 3 minutes because it has the pause. Here again, another. Okay. So this was to have a complete idea of everything the machine can do. It can also be synchronized with EEG, so you would also have a guided TMS. You would also have the registration of maps if you want. So there are any other modules that you can set up to the machine in when you choose what you want to do with the machine, what you want to have available. Also, another difference would be the coil. We have chosen this one for its capability to reach deeper areas than a flat coil. But we also have a shunt coil. We have a double-sided flat coil in which we have the possibility to have a placebo stimulation in double blind, because neither the patient, the subject, or the operator knows which stimulation is performed by the machine, which randomly assigns the subject to a placebo or real stimulation. And speak for, I believe, the closing. Thank you.
Any question?
Thank you.
Thank you. A lot of thank you. So you collect a lot of thank you. It's better than
Thank you.
money.
Very clear.
Very
Thank
clear
you.
indeed. Okay, thank you. So it was a great presentation. Thank you so much, Anna Maras.
Thank you.
It's evident that she is very familiar with all this procedure and device, because she is really the head of a technical, how do you say, people that is giving the TMS to patient every day, and so she's very familiar with any kind of neuromodulation, especially with TMS. So if there is not any further question, I guess it would be much better in person. I wish next time we can make in person, and the purpose was to involve each of the attendants in a practical setting. This is why originally the schedule involved like 4 hours of this practical activity. Unfortunately, COVID-19 doesn't allow to make it. There is a question?
Let me read.
Let me see.
If I manage to. If I need any assistance in delivering TMS, may I contact you? Of course. Of course.
Okay.
Can you share again the screen for low frequency as the main parameters? Yes. Okay.
Yeah, because you know this, of course, you need to know all the background, the protocol, but when you set this up, then you have to become familiar with handling, the device, the coils, and the screen, and you have also to check every time everything you are doing, because it's important that all the parameters, the reproducibility is extremely important, either in a research setting as much as in the clinical one. So thank you, Anna, for this very clear presentation that I guess is the last one, and so we can, if there is not any comment or discussion, I think that we can close now this first workshop on TMS, on OCD spectrum and addiction and depression also. It has been our pleasure to have you here now, late in the here in the afternoon of Saturday. So thank you for dedicating us this large part of your weekend. And we will send you the key slides, the certificate of attending for whoever needed. And we will keep informed about the next workshop that we plan to make in next fall, this fall.
Yeah.
Hopefully in person. Otherwise, it will be a new webinar that is much convenient, but is also we know that we are missing something of the practical things.
Do we need to request the certificate? Yes, please send us an email, those who need the certificate, so we will have a clearer list of the people who need the certificate. Yes.
Thank you for the Anya, what's the name?
Yes. Let me go down. If I can read, sorry, we have some messages that have been left down. Let's see in full screen.
Yes, the recording will be on the site, so all the questions that you have will be answered.
Yes. Now we have some issues with scrolling down the chat. Sorry, just at least some problems, technical problems.
Yeah.
Okay. So we have read some thank you. We thank you.
Thank you so much from Florence, Italy, and see you next time. Soon.
Great experience. Thank you.
Thank you.
Thank you. Bye bye. Bye all.
Bye bye.